Hello everyone, this is Bahadur Güllüoğlu from Istanbul. First, I would like to thank the organizing committee and Maher for their kind invitation. Here in my assignment, I will be talking about the safe margin after breast conserving surgery, both after upfront surgery and neoadjuvant treatment. So the aim of surgery in cancer treatment is to decrease the recurrence and increase the survival. This is the issue both for mastectomy as well as the partial mastectomy, or in other words, for breast conserving surgery. The critical question here is, what is the optimal width of margin to say it is safe and adequate? So far, what we know from the cohort studies is that when we have wider margins, we have a less recurrence. But is it enough to conclude that we need the largest margin in each patient? In a recent meta-analysis, the authors showed that there is, in fact, no difference between groups of patients with different margins. The ones with no income tumor had the similar recurrence compared to those with wider margins, including those with more than 5 millimeters. And after all those discussions over the studies, authorities came to a consensus saying that if a surgeon gets a margin of no income tumor, the patient does not need a further resection to obtain a larger margin. So we adapted this policy since 2014. However, there are controversial studies that made us to raise our eyebrows, like this one from the States back in 2016. In this retrospective study, the authors re-resected those patients who underwent breast conserving surgery with negative margins, but less than 2 millimeters, and they found that in half of the patients, the tumor was still there at resected specimen, meaning that otherwise these patients will remain with cancer in their breast. Again, in a similar study from the Netherlands, the authors found that 55% of patients had cancer beyond the original lumpectomy margin after they did a re-resection, although the margin was negative in the first operation. But these findings should have not surprised us if we would have remembered the findings of these three historic studies, in which they found that although the clinical and imaging findings suggested that there is single tumor after mastectomy, the through sections revealed that only 40% of those had unifocal tumor, meaning that more than half of the patients, in fact, had multifocal and multicentric tumors. And nearly in half of the patients, these extra cancers were found at a distance larger than 2 centimeters from the cancer primary, and 2/3 of those extra tumors were invasive cancers. And this finding was consistent with the other two large studies that I mentioned. So again, in 2019, the St. Gallen Conference, all the panels repeatedly approved that no income tumor is sufficient margin to say the tumor margin is free and safe. But would it be a valid recommendation for young patients in which we believe that a recurrence a bit higher overall after breast conserving surgery compared to the elderly patients? To answer this question, we may look at the results of the POSH study, which is an observational cohort study in patients who are less than 40 years of age. And here in this study, again, they found that the authors found that the margin width had no significant effect on in-breast recurrence. So the recent updated recommendations for young breast cancer patients states that there is no need to achieve larger than no income tumor margin in young breast cancer patients. Again, another question, a valid question, is should we change our practice for surgical margin according to the tumor subtype? From a large population registry database, this is from Germany, we know that in-breast recurrence rates differ according to the tumor subtype, having that luminal tumors have less recurrence where triple negatives have the highest. But does this finding have anything to do with the margin width? In other words, should we try to leave larger margins in more aggressive tumors such as triple negative cancer patients, or less and less in those with luminal cancers? In a recent study, even in the most aggressive tumor subtype, which is the triple negative cancer here, whether you achieve less or larger than 2 millimeter margin, they found that the patients got similar recurrence rates. Even in HER2 positive cancer patients, the risk of having recurrence is related to its biology, and also to whether the patient received the adequate targeted treatment. This registry study from the Netherlands clearly showed that if the patient receives anti-HER2 treatment, the recurrence rates decreases to the level of those found in luminal cancer patients. Again, all these findings are not surprising when you consider the effects of adjuvant treatments. Almost all studies show that not the margin width, but the receiving adequate adjuvant treatments were the significant independent factors for in-breast recurrence. Even tamoxifen was found to decrease the recurrence by about 40%. Contemporary non-selective chemotherapy with taxanes also found to decrease the in-breast recurrence by nearly 70%. Least but not the least, anti-HER2 treatment was found to decrease the in-breast recurrence by 90% in HER2-positive breast cancer patients. Nonetheless, we all know the impact of neoadjuvant systemic treatment in breast cancer patients, where according to the subtype of the tumor, it is possible to achieve complete pathological response from 16 to 50% of the patients. Therefore, there is definitely an impact of biological treatment on in-breast recurrence rates after breast-conserving surgery. Even the National Guideline of Netherlands proposes that up to 4 millimeter focal positivity on the margin is regarded as negative margin and suggests no further surgery to obtain clear margin in these patients, regardless of the subtype. Despite this recommendation, in a separate study, surgeons did re-resect some of these patients, those with the positive margins up to 4 millimeter focal positivity, and they found that in half of those patients, there were remaining tumor in the re-resected specimen, similarly that I showed you in the previous slides. So what happened to the rest of those patients who did not undergo re-resection, although they had focal positive margin? After 5 years of follow-up, only 3% had in-breast recurrence, which is almost similar to those who had negative margin in the beginning, provided that all patients had whole breast radiotherapy. Also, the 10-year overall survival was similar in both group of patients. So as a conclusion, for upfront surgery in invasive cancer patients, it is safe to say that the adequate margin is no income tumor. A more extended clear margin would not matter because we already know that how wide you excise the tumor, 50% of the time there remains tumor behind, and this does not cause difference in mortality. Tumor biology is the governing factor, and adequate biological treatment have a significant impact on both local control and overall survival. So, what about the safe margin after neoadjuvant systemic treatment? Should it be different than that of we suggest in upfront surgery? Here we have a more complicated situation where the tumor may downstage in size in different structures. One may shrink concentrically, the other may shrink in a way that pieces of scattered tumors may remain with partial downstaging. And here, the resected the remaining tumor may not be complete due to the variability and the non-uniformity and formless distribution of tumor cells within the original cancer site. There are a few studies which shed light in this issue, which I think give us some idea for our practice. The very first of them is from Spain. Here in this study, all patients had clear margins, and the patients were stratified according to the margin, their margin width, and the authors did not find any difference whether the margin is less than 5 millimeters or more. In another study from Austria, again, all patients had clear margins, and the authors found similar in breast recurrence rates in patients who had less than 1 millimeter safe margin versus those with larger. Let's surprise you more with this study from Japan. Here, the authors compared those patients with positive margin to those with negative. Although they did analyze in-breast recurrence rates, the overall recurrence, including those with positive margins, is less than 2% after 50 months of follow-up. And the overall recurrence was similar in both groups. Again, the margin is positive, and they are seeing less than 2% of recurrence in breast recurrence. A similar study from Japan again showed a similar result, indicating that even having a positive margin again has no impact on recurrence in patients who receive neoadjuvant systemic treatment. Even in those with positive margins, the overall recurrence after 4 years follow-up was found to be, again, less than 3%. And the final study comparing different margin widths is from the States. In this study, those patients with closed margins, meaning those with positive or less than 2 millimeters margin, had less than 3% of recurrence. Again, 3%, less than 3%. Those patients who had larger margin even had more recurrence in absolute numbers. Of course, this is not meaningful, but the thing here is that should be underlined is that even you have positive or closed margin, you have less than 3% of recurrence. But I should remind you that all these studies are retrospective or prospective cohort studies, not randomized studies. In larger cohorts, it was found that not the margin, but other factors were found to be related to local failure. So this again underlines the impact of biology and adequate treatment accordingly. Even in those patients who had mastectomy, the largest margin you can obtain in breast cancer patients, because this is mastectomy, it's not breast conserving surgery, so reach the boundary of the gland. If the cancer is triple negative, the recurrence rate is high again. Therefore, the extent of a surgery has an impact on recurrence less than we expect, especially when we think according to the subtype, the aggressive subtypes. Again, this emphasizes the role of biology in disease management. And apart from all those studies, International St. Gallen consensus in 2019, panelists favored no-income tumor as a safe margin for both unifocal and multifocal residual diseases. As a conclusion, wider margin after neoadjuvant treatment does not have an impact for better local control. Also, margin does not have an independent impact for overall survival. At the bottom line, extensive surgery does not compensate systemic treatment failure, such as in the example I showed you for triple negative cancer patients. So thank you very much again for the kind invitation and your attention. I hope my talk gave you a sense of understanding for the role of surgery on breast recurrence in each setting, both upfront and after neoadjuvant treatment.
Thank you very much, Dr. Bahadir. It was, as usual, a very interesting talk. Definitely you stressed upon the importance of adjuvant treatment and innovations that happen. Definitely we all rely on radiotherapy, the modern techniques of radiotherapy and targeted and new chemotherapeutic agents that definitely we can see, even we have a microscopic residual tumor, and these are overcome by this adjuvant treatment. I just want to ask you about, in the neoadjuvant setting, about the margin itself. You definitely, we all do the wider margin. It's not important for all of us to have a good outcome and no recurrence. It does not add to the protection of the patients. As in oncoplastic surgery, for example, we do wide excision, and this does not add to the patient. I just want to ask you about the size you excise after neoadjuvant chemotherapy. After the patient finishes her chemotherapy, and do you excise it on the original tumor or on the size you have it? Because as you demonstrated, you have concentric shrinkage of tumor, and sometimes you have a Swiss cheese pattern of shrinkage. How you assess such an issue?
Thank you so much for this question. This is a very important question because most of the time everybody is asking the same question. So here, the issue, although I say that no-income tumor or even a positive margin would not make any difference in the outcome, both in the recurrence and on the survival, but we still try to obtain a clear margin in these patients. As a surgeon, of course, we would like to have a larger margin as we can do. And here, if in the beginning, there's, let's say, a 4 centimeters tumor, and in the end of the neoadjuvant chemotherapy, if there's a complete response radiologically, and there is no microcalcifications left in the mammogram, then it is safe to do only a very, very limited resection to remove the clip that you left in the beginning. So that is my practice, and I didn't see any disadvantage of doing this type of a surgery, because most of the time, 80% of the time, it is concordant with the radiology, what you had in the end of the pathological assessment of the specimen that you resected at the end. But if, of course, the imaging is very important at the end of the neoadjuvant chemotherapy, when you're planning the surgery, your surgery. So here, if there's a concentric shrinkage, then it is again safe to only excise the tumor left behind. So here again, the margin should be minimum no-income tumor, but it would be safe, of course, to have, let's say, 2, 3, 4 millimeters. You can go up to 1 centimeter, or if you do an oncoplastic surgery, you would have a wider margin. But as I showed you, there is no difference whether you have no-income tumor or you have 1 centimeter of a margin at the end of an oncoplastic surgery. But the oncoplastic surgery in the beginning should be planned in order to get a good aesthetic outcome. So always we just combine two outcomes here. First, of course, the safe surgery in oncological means, and the second is the aesthetic outcome. But here I showed you the data, although they are retrospective, there's no difference. So the aim of the oncoplastic surgery is also one of the main outcomes, is the aesthetic outcome. So, but if there's no concentric, shrinkage, then of course, when you see it on the mammogram with the microcalcifications, because that's mostly the issue there, because you have to remove all the microcalcifications left behind. So you have to make a larger resection in order to remove all seen visible tumor in whether in MRI, ultrasound, or mammography.
Okay, and another question?
Really, I have two questions. First question, after receiving neoadjuvant chemotherapy, some patients went to PCR with residual in situ carcinoma. Right. If I have residual in situ carcinoma at the margin, should I redo or should I re-admit the patient to the OR and do remargin? Or this residual DCIS at the margin can be managed by radiotherapy? Second question, is there any indication to omit re-excisions in cases of positive margins in primary conservative breast surgery? Thank you.
You asked the same question in two settings, as far as I understood. Is that correct?
Second question, in the primary conservative. In the primary conservative breast surgery.
In the margin, there is a DCIS. Is that correct?
Second question refers to if I have positive margin.
Right.
If I have positive margin, invasive carcinoma at the positive margin, are there any special circumstances that I can omit re-excision, or all patients must redo re-excision? First question about the neoadjuvant, residual in situ carcinoma at the margin after neoadjuvant.
Okay, I very well understood now. Thank you very much for these two beautiful questions. They're very important in our clinical practice. I'm starting from the last one. So if there is a positive margin in your upfront surgery and it's an invasive positivity, of course you have to discuss this with your radiation oncologist. I mean, because this should be a decision making after you consult to your colleagues in medical oncology and radiation oncology. But from my point of view, what I can tell you that if it is simple to do a re-resection, and at the end, because you have a specimen, you can go back to the pathology lab and just see how much the involvement is in the specimen. Plus, you may ask an MRI to see whether there's any, macroscopic or microscopic, but, extended remaining tumor in the breast. Then you may go on for re-resection. But if this is a difficult, alternative, because you made, let's say, an oncoplastic surgery, it is very difficult to find the place to re-resect, and the only option is to do a mastectomy, and it is a limited, involvement of the margin, then I always remind this Netherlands guideline, which is up to 4 millimeters of focal positivity can be regarded as negative margin. So this is a discussion that you should do with your radiation oncologist. But what I can tell you, there is a valid option to remain with the patient with a positive, but, minimal positive margin in these cases. But this should be discussed with your patient not only with the radiation oncologist or the medical oncologist. And you should consider the post-operative imaging, especially with an MRI. Okay, the first question was about the in situ, the remaining in situ, the positivity in the margin. So this is really, there's no one straight answer to this question. What I can tell you that a very recent study published from the I-SPY study show that there's no difference whether you have a remaining inside a cancer or a pathological complete response at the end of the neoadjuvant chemotherapy. But I am just telling you that the remaining tumor, not the margin positivity. So here, the issue is different. Why? Because although we say that there is no difference in survival, whether there is a remaining inside the cancer or complete response, no tumor at all. Therefore, the patient mostly had something similar to the PCR. So here, any risk which can increase the recurrence should be eliminated. That is why I would recommend here to do a re-resection. So this is a different opinion, a view of opinion, but why? Again, I am telling you that although inside is maybe you would seem that it's a harmless thing, but here you're supposed to have a very good prognosis in these patients, and there remains only one risk. I mean, the major risk here is the recurrence in the breast. So here, I can tell you more strongly that you need a re-resection in these patients.
Thank you.
Any more questions? Thank you very much, Dr. Bahadir, and it has been a nice talk. And as usual, we hope to see you next time in face and physically among us here in Cairo or Alexandria. Thank you.
Next time, sure.
Thank you very much.
Thank you.
Next speaker, Dr. Ashraf Abul Futuh. موجود? He will give a talk about an algorithm for post-mastectomy microvascular lymphatic reconstruction for breast for lymphedema after mastectomy.
Good afternoon. Good afternoon, everyone. Thanks for inviting me to such a great event. So I will speak about, as plastic surgeon, I would speak about the post-mastectomy microvascular breast and lymphedema reconstruction. I hope most of the videos work because the guys in the audiovisual couldn't work some of the videos, so I hope most of them will work. In the context of the post-mastectomy, we encounter three categories of patients as plastic surgeons. Patients coming just for lymphedema reconstruction, and patients coming just for breast reconstruction, and a third category of patients coming for both breast and lymphedema reconstruction. For the first group, the patients coming for lymphedema reconstruction, currently we classify lymphedema patients into two categories: fluid predominant and solid predominant disease. We can differentiate between them clinically and also by investigations like the classic investigations, lymphoscintigraphy, MRL, CT angiography. However, the breakthrough in lymphedema investigations is now the endocyanine green lymphography. We have this machine since April 2021 in Cairo University, and we were the first to use the machine. ICG lymphography is the eye of the surgeon. It shows the lymphatics preoperatively, intraoperatively, and postoperatively. So preoperatively, it shows the functional lymphatics, and we will know soon how important is that. Intraoperatively, it's used for mapping of the lymphatic vessels. And postoperatively, it's used for the follow-up of the patency of the investigations. this is how a functional lymphatic would show in an ICG lymphography, like a linear pattern, white linear pattern in the ICG. Second tool that we use is the color Doppler ultrasound, and we are all aware of the advantages of the ultrasound opposite the other investigative tools. And the role of ultrasound in the diagnosis and differentiating the different types of lymphedema is established in the literature. Simply the presence of fluid in the dermis, subcutaneous tissue, and the superficial fascia would indicate a fluid predominant disease, and this is where a physiologic operation would be a valid option. So what we do is that we compare the lymphadematous with the normal limb, and we define the axis of the upper limb by joining 3 points, midpoint of the wrist, midpoint of the elbow, and the bicipital groove. And then we define 3 assessment points, a point at the elbow and point 10 centimeters above and 10 centimeters below the elbow. If we can see, the left side is the lymphadematous side, and you can see a mixture of hyper and hypoechoic shadows, while the right side is the normal side where you can find a homogeneous pattern. The presence of fluid in the skin and subcutaneous tissue is the key to diagnose a fluid predominant disease. So whenever we have a fluid predominant disease and we have a functional lymphatic by the ICG lymphography, we can offer the patient the LVA. What's the LVA? The LVA is a connection between the lymphatic vessels and the veins to bypass the obstruction. So using the ICG lymphography for the lymphatics and the ultrasound for the veins, that's a patient of a fluid predominant breast cancer related lymphedema. And using the ICG lymphography, we could detect a linear pattern, which we said that this would indicate a functional lymphatic, and then we mark that on the skin. And using the ultrasound, we can define the vein. And for the vein, we have certain things that we need to make sure of. Number one, that it is a vein. Number two, it is nearby the lymphatic. So the size match with the lymphatic, the patency of the vein, and it's a reflux-free, and we can use the ultrasound for all of those. So the shape is different between the lymphatic and the vein. So the vein is usually round, while the lymphatic is a spicular, misshapen. The vein is compressible, while the lymphatic is not. The color mode, of course, and the size match, we can measure the diameter of the lymphatic and the vein, and intraoperatively we can double check the diameter, the patency with compression, and also lastly the reflux-free, because we need to do the anastomosis on a reflux-free vein, and we do that by challenging the valves by distal compression. Now, the super microsurgery setup is composed of the microscope, the super microsurgery instruments, and the super fine sutures like the 11 and 12O. Intraoperatively, we can double check what we have seen in the ultrasound by the micro ruler. So here we could find a lymphatic which is 0.75 millimeter and a vein which is 1 millimeter. And then we joined both using the microscope. And after the anastomosis, we check with the clinically with the patency test. And you can see the passage of the blue dye from the lymphatic to the vein, indicating a patent anastomosis. And on the right, we can see also an ICG patency test. And you can see passage of the a white dye from the lymphatic to the vein across the anastomosis. And that's the patient post-operatively with very nice improvement of the lymphedema. That's another case, and again, we could find the lymphatic and the vein, and using 11O, we could join them together. And again, the patency test with passage of the blue dye, and the ICG test with passage of the indocyanine green from the lymphatic to the vein across the anastomosis. And that's the patient post-operatively with very, very nice improvement of the lymphedema. And actually, I always say that the most important thing is not just the mere reduction in the volume or circumference of the limb, but also the softness and the suppleness. In the lymphodematous limb, you cannot pinch the skin like this. We all know the classic appearance of the lymphedema arm. So here you can see the softness and the suppleness of the tissues after the LVA. What if the patient does not have a functional lymphatic by ICG lymphography? So in this case, we offer them another type of physiological operation, which is the vascularized lymph node or vascularized lymph vessel transfer. The vascularized lymph node transfer that we use is the submental flap. Submental flap is based on the submental lymph nodes, which is supplied by the facial submental artery and vein. And it can be used with a skin island or without a skin island. And again, we use the color Doppler ultrasound to check for the recipient site and for the donor site. That's a fluid predominant patient with no functional lymphatics, so a decision of submental lymph node was taken here. And then we use the color Doppler ultrasound to check the recipient vessels. The recipient vessels here in the forearm are the cephalic vein and the radial artery, which can be easily detected by the ultrasound and marked on the skin. We can also check the vessel diameter to plan for the anastomosis. And we can check the flow velocity of the radial artery to follow up after anastomosis. That's intraoperatively, and we could confirm what we have seen with the ultrasound, the cephalic and the radial artery. The ultrasound is also of benefit to the donor site. So again, we can check the donor vessels, which are the facial and submental vessels here. And again, we can check for vessel location and mark that on the skin, and vessel diameter to plan anastomosis and flow velocity of the facial and submental artery. That's intraoperatively, we can check the facial artery and the facial vein. The lymph nodes also is very important to check with the ultrasound because we can decide whether to take the right or the left submental area by checking the number and size of the lymph nodes in the right and the left side. So in this particular patient, we had 2 sizable lymph nodes on the left side and 1 small one. On the right side, we had only 1 sizable lymph node, so we decided to take the left side here. And that's intraoperatively when we separated the flap, and we can see clearly the 2 lymph nodes that we have already seen with the ultrasound. We have seen them, and that's a more clear picture of them. Even the margin-mandibular nerve can be seen and planned to be saved during the surgery using the ultrasound. And using the nerve stimulation intraoperatively, we can check the margin-mandibular nerve and save it during harvest of the flap. So that's the flap after harvesting, the facial artery, facial vein, submental lymph nodes, and the margin-mandibular nerve. Because we have seen already by the ultrasound that there is a discrepancy between the facial and the radial, so we decided an endocyte anastomosis already. So that's the flap after anastomosis, and you can see the 2 lymph nodes visible and the facial artery anastomosed endocyte to the radial artery almost at the rest. That's the patient day 1 post-operative, and you can see the patient with no affection of the margin-mandibular whatsoever, and a nice clean wound at the rest. And that's the patient post-operative with very nice reduction in the circumference of the limb. And that's another patient in which we almost achieved cure. You can hardly see any difference between the lymphadematous and the normal side after the lymph node transfer. And again, it's not just the circumference, but also the suppleness and the resolution of the manifestations that the patient report after the surgery, that the limb became less heavy and less painful and so on, and she can resume her daily life normally. The third option for a fluid predominant disease after LVA and vascularized lymph node transfer is the vascularized lymph vessel transfer. And for that, we use the skip flap. And the skip flap is based on the superficial circumflex iliac artery, branch for the femoral artery. And again, we use the ultrasound for planning. So ultrasound is used for the recipient vessels and for the donor site. here, the recipient vessels, we tend to put the skip flap in the axilla. So the recipient vessels would be the axillary subscapular system here. And we can check that with the ultrasound. And the donor vessels, as we just mentioned, is the superficial circumflex iliac artery, the medial branch of it, and the vein. Ultrasound also can help in checking the vessels. So that's the femoral artery, that's the superficial circumflex iliac artery, and then it divides into a superficial branch and a deep branch. And then we try to center the flap over the superficial branch of the vessel. And that's how we see also when the vessel penetrates the deep fascia and the superficial fascia in order to make the final planning of the flap. Again, we can measure the diameter of the vessel, and that's the SCIV, which is the superficial circumflex iliac vein, which is the branch tributary to the femoral vein, usually in a common trunk or separate with the superficial inferior epigastric vein. And we can check also the diameter of the vein and the points of penetration of the fascia to the vein. And that's the final plan of the flap. Skip flap has no lymph nodes. However, if we decide to take it with lymph nodes, it's very easy to check with ultrasound as well the groin lymph nodes. That's the flap after harvesting. We start by checking the vessels, and then we commit to the rest of the flap. That's the flap after insetting in the axilla. What if the patient has a solid predominant disease from the start? So in this case, we offer the patient a liposuction, which can later be followed by a a physiologic operation if she developed functional lymphatics later on. So that's liposuction, which can be also combined later with a skin excision in the same setting or later. That's our last patient we did like 3-4 weeks ago with huge solid predominant disease in the arm, and that's the patient on table after liposuction and skin excision. Now, the second category of patients that we encounter as plastic surgeons in the post-mastectomy context is patients coming just for breast reconstruction. And for those, we use a free flap, which is the supraarcuate fascia muscle sparing tram, which is a modification that we have added to the muscle sparing tram flap. So in our practice, the abdomen-based free flaps represent the gold standard in the armamentarium of breast reconstruction. And in 2012, we have conducted a study, which I think was the first to be done in Egypt, about the free flap in breast reconstruction. And it was a comparative study between the deep flap and the free tram flap. And the result was matching the literature that always the deep flap reduces the abdominal mobility but increase the flap-related complications in comparison with the free tram. So when we compared the deep and the tram flap, the answer was the muscle-sparing tram flap. Why we do that? Because it keeps the balance between the flap complications and the donor site morbidity. So what's the problem? The problem is obesity. So it's well established in the literature the effect and the hazard of obesity as a risk factor over the donor and the recipient sites. It's a problem, and all the complications are increased in the obese population. So that's why we modified our muscle sparing tram technique to use the fascia sparing, and we spare as much as fascia in the harvest of the flap, and then we stop our dissection at the arcuate line. That's why it's called a supraarcuate technique. We start this by perforator detection. I'm not sure if the audio is going to work now. ممكن صوت يا جماعة؟ في صوت؟ Anyway, that's a Doppler detection of the perforator of the flap. And then we start marking of the donor and the recipient vessel, sites. And a two-team approach is usually practiced during this technique. So the chest team starts with preparing the chest area, either an immediate after the surgical oncologist would do the mastectomy, or a delayed case when we recreate the pocket and go to the third costal cartilage, removing part of that, and going to the internal mammary vessels getting a good length of the vessels to facilitate the anastomosis. In the immediate case, the video that does not work on the left side, we would be keen to check the hemostasis after the mastectomy and the vascularity of the skin flaps, which is very important, and also rebuild the footprint of the breast if it was violated by the surgical oncologist. In the bottom video, the abdomen team would start harvesting the flap, and as we said, it's a muscle-sparing tram flap. However, also it's a fascia-sparing tram flap, so you can see here that we have spared like 5-6 centimeters of the medial and the lateral sides in order to reduce the fascial harvest and facilitate closure and reduce the donor site morbidity. And we stopped our incision downward until the arcuate line, as you can see here, sparing around 5-6 centimeters from below as well. After that, we clip the inferior epigastric vessels. And you can see here that we have spared all the fascia below the arcuate line, which is natively weak due to the deficiency of the posterior rectus sheath as the lower fourth of the anterior abdominal wall. Next, we do the microvascular anastomosis, deep inferior epigastric to the internal memory, and then we do the 3D shaping of the breast, and then we do meticulous closure of the already spared fascia, and sometimes also we add a supraumbilical and contralateral application of the fascia in order to strengthen the abdominal wall and centralize the umbilicus. That's the patient after the final closure, and the same patient was shown 3 months from the surgery with very nice, supple, soft flap with no evidence of fat necrosis. And of course, she is awaiting symmetrization and nipple area reconstruction later. So that's the result that we could achieve with the classic free tram flap, and you can see still there is a bulge in the abdominal area. After using the free muscle sparing tram, you can notice here the improvement at the level of the abdominal contour. Of course, we use that for immediate and for delayed and for delayed immediate reconstructions. After using the supraarcuate technique, we could reach that excellent donor site result, and you can see a nice flat abdomen. And again, we use that in all the types of reconstruction, immediate, delayed, and delayed immediate reconstruction. And you can see that most of the patients are of the high body mass index population. Also, this technique has reduced our bulge incidence from 23% into 3%, and the hernia from 6.7% into 0% so far. And also, the quality of the life questionnaire has shown an improved patient satisfaction after modifying the technique. So that's the result after classic free tram, that's the result after free muscle sparing tram, and that's the result that we see now after the supraarcuate fascia muscle sparing tram with excellent improvement in the donor site. So we advocate that supraarcuate fascia muscle sparing tram flap to reduce abdominal site morbidity while still maintaining a safe and optimal flap perfusion in obese patients. The last category of patients that we encounter are the patients that's coming for both lymphedema and breast reconstruction. And of course, we can manage the lymphedema and the breast sequentially by doing the lymphedema alone as before and the breast alone. But we can also manage them simultaneously by using the so-called combined approach. So what's the combined approach? The combined approach is combining two procedures, which is aesthetic breast reconstruction and lymphedema reconstruction in one single operation. So we call it the 2-in-1 technique. So what we do is that we take the abdominal tissue as before to reconstruct the breast, and in the same time we take the inguinal lymph node to reconstruct the lymphedema. And then we rotate the flap 180 degrees so the lymph nodes would fit in the axilla. Anatomically, we should stick to the lymph nodes between the superficial inferior epigastric and the superficial circumflex iliac veins, and avoid the lymph nodes that drain the lower limb. Surgery starts by marking, as usual, and as we Doppler the deep inferior epigastric perforators as before, we also Doppler the superficial circumflex iliac artery, which is the blood supply of the lymph node flap. And then we do the marking of the donor and the recipient sites and marking of the inguinal lymph node flap. And we use reverse mapping for to check that we are not harvesting the lymph nodes of the lower limb. And for the reverse mapping, we use the technetium that's injected 2 hours before the surgery in the web spaces, and we use also the patent blue in order to check for the lymphatics of the abdomen. And with help of our colleagues from the nuclear medicine, we could check the sentinel lymph node and mark it on the skin in order to avoid harvesting that with the flap. That's the flap extension, technique of the flap, reverse mapping. That was a video as well that shows that we still have the high signal of the gamma probe in the sentinel lymph node that we have marked in the beginning. So, and there's very, very minimal activity of the gamma probe over the lymph nodes, which means that we have spared the lymphatics of the lower limb. And then we harvest the abdominal flap as we have discussed before, and a liberal axillary scar release is very important, and preparation of the recipient vessels. That's the flap after separation, the abdominal flap for the breast, and the inguinal extension for the lymphedema. And then here we did a double anastomosis, the deep inferior epigastric to the internal memory, and the superficial circumflex iliac to the thoracodorsal in the axilla. That's the flap in sitting, and that's the final closure. We have done many cases with the same technique, with nice improvement of the
time.
Okay. I think they said 20 minutes, right?
It's 20 all over. Already it's 20.
Ah,
Already
okay.
passed.
I have less than a minute.
Okay.
That's the second case. Nice improvement of both the breast and the lymphedema. And note the improvement of the depressed axillary scar. Another case, improvement of the breast and the lymphedema. A fourth case, and that's the last case. So that's our algorithm for post-mastectomy patients, and it's all about teamwork. In microsurgery too, I have to thank my team, the microsurgery team, and the oncology and physiotherapy team, which were keen even to meet during the COVID area. And thank you very much.
Thank you, Dr. Ashraf, for this wonderful talk. Actually, questions will be postponed till the end of the session. Dr. Ali.
Thank you so much. And I would like to present the next speaker. It's Dr. Omar Farouk, the good friend of Uzbekistan and the most romantic and poetic breast surgeon in Egypt, I think. So his lecture is dedicated to the granulomatous mastitis. So, Dr. Omar Farouk.
Assalamu alaikum. Good evening. It is my great pleasure to attend this big conference. Thank you, Sherman. Thank you, Ali. Thank you, dear colleagues, for attendance. It is a big dilemma, granulomatous lobular mastitis. The first ones who discover or describe this disease were Israeli researcher called Kessler and Walsh in 1972. But Going and colleagues in 1987 recommended the term of granulomatous lobular mastitis to be used as being more specific to differentiate this disease from the ductal inflammatory conditions. In 2012, Berriera and colleagues recommend the term of idiopathic to added to granulomatous lobular mastitis to be used, which more descriptive. However, recently we have shared with 60 experts from more than 16 countries in an international multidisciplinary consensus, and we widely And we recommend to use granulomatous lobular mastitis term as a widely accepted definition. So what is granulomatous lobular mastitis? It is a benign non-caseating condition. It is a benign chronic inflammatory condition characterized by non-caseating granulomas with microabscess formation confined to the breast lobules. It is mostly seen in females with childbearing age within 5 years of the last pregnancy, weaning, and associated breastfeeding. Diagnosis, pain, breast masses, subcutaneous collection, and sinus formation, usually the first manifestation. Skin changes like erythema, edema, ulceration, sinuses were reported in about 66% of patients. Axillary lymphadenopathy is present in about 15 to 30% of patients. The incidents are the same in post-breast, but mostly, usually, it is unilateral. Diffuse involvement was seen in 30% of patients. Upon resolution, common sequelae are scarring and skin retraction. No pathognomonic mammographic features for granulomatous lobular mastitis, but parenchymal heterogeneity with focal asymmetrical density corresponding to the palpable mass, architecture distortion, and irregular masses or nodules are common abnormalities. Ultrasound is the main tool for diagnosis. It reveals heterogeneous, irregular, hypoechoic mass lesions in more than 80% of cases. Tubular hypoechoic configuration areas with finger-like structures connecting to the mass occurring in about 50%. Sometimes, in absence of mass lesions, ultrasound evidence of areas of mixed echo pattern with parenchymal deformity, multiple collections, pockets, and tracts, focal mastitis with interstitial edema may indicate the presence of an inflammatory granulomatous process. So both clinical and radiologic findings are not sufficient to diagnose granulomatous lobular mastitis. So the role of radiologic investigation mainly is to exclude the possibility of malignancy rather than confirming the diagnosis of the disease. So core needle biopsy play an important role in diagnosis. The major histopathologic changes is lobulocentric, non-caseating inflammatory granulomas that differentiating the disease from TB mastitis, in addition to microabscess formation, which is commonly observed. So what the etiology or pathogenesis of the disease? It is an inflammatory reaction, and the localized granulomatous response are triggered by presence of extravasated secretions and milk proteins within the interstitial breast tissues resulted from rupture of breast lobules as a consequence of microtrauma from breastfeeding or milk stasis due to obstruction caused maybe by local irritants or undetected infective microorganisms. So the milk stasis plays a key role with breast tissue developing into hypertrophic and fragile state consequent to pregnancy, lactation, hyperprolactinemia. Some authors claimed autoimmunity. However, most of cases cases with comorbid autoimmune disorders represent only minor fraction of all cases. Also, serologic markers tests of autoimmune disease like ANA and rheumatoid factor are usually negative. So the infective theories start to come strongly in this disease. Taylor from New Zealand in 2003, the first one who discovered the role of Corynebacterium and detect Corynebacterium in about 50% of patients, and most of these pathogens are Corynebacterium chrobin-stiditi. And after 2017, most articles start to describe the infective theory. Many articles here from Australia prove the role of Corynebacterium and describe widely the Corynebacterium chrobin-stiditi as a main pathogen in this disease. Also, this case report from Sweden described the role of rickettsia. Most of these pathogens or microorganisms occur in the gap between the Corynebacterium and a typical Mycobacterium. And recently, this article from China proved many organisms in the disease and recommend the treatment by lipophilic antibiotics like rifampicin, in addition to prolactin inhibitors. The question now is why the granulomatous lobular mastitis usually occur in Mediterranean region and some areas in developing Asia. The prevalence might be the reflection of underdiagnosis of TB mastitis. Sometimes routine histology studies are not sufficient to rule out the diagnosis of TB. Also, presence of atypical Mycobacterium may be involved in the pathogenesis of granulomatous mastitis, which are difficult to isolate under routine culture conditions. Also, this disease is related to the habits of lactation and weaning that may lead to milk stasis, which is the most important predisposing factor. We have noticed in practice that some patients depend on lactation from one breast only and neglect lactation from the other one, which has more risk to develop granulomatous lobular mastitis. Many patients neglected the routine breast massage and the complete evacuation of post-breasts after each time of lactation. Many patients also neglect the same routine breast massage and complete evacuation of post-breast during the first weeks of weaning. Another risk factor for developing granulomatous mastitis, which is hyperprolactinemia, caused by long-term use of antipsychotics. And here in this article from China, all patients treated successfully with bromocriptine. So what is the treatment or ideal treatment of granulomatous lobular mastitis? Till now, there is no consensus. Also, there are no randomized controlled trials demonstrating the efficacy of any treatment modalities up till now. The first line of treatment is observation. Spontaneous resolution of granulomatous lesions may occur in 50% of patients without any treatment within 1 year. So this is suitable only for small unifocal lesion with mild symptoms, and also it is highly recommended during pregnancy. A recent study from Turkey investigated the watch and wait strategy or observation versus the corticosteroid and revealed it is a good option. However, the recurrent rate is about 11.9%. So we had not the selection criteria of patients who are patient will take a good option of observation and who will take the treatment. So the second line of treatment is surgery. Wide local surgical excision is often done to localize uncompleted discrete mass. Clear margin is mandatory to avoid unnecessary mastectomy and need of subsequent therapies. However, the recurrence rate after surgery alone ranging from 35% to 50%. Also, repeated surgical intervention had poor cosmetic results and even massive contour deformities of the breast and repeated abscesses development in many cases, as we see in this photo from our practice. Some authors use skin sparing mastectomy and immediate breast reconstruction using autologous flaps as a suitable alternative surgical choice for diffuse or multifocal granulomatous lobular mastitis, but sometimes it may be ineffective because abscesses recurred from the residual breast tissue. So the surgery is not also the ideal line of treatment. What about corticosteroid? It is widely used all over the world. The first one who discovered this and used high dose of prednisolone was Dehertov in 1980, and since that date, corticosteroid became the first line of treatment. The current dose is 30 milligram per day for 3 to 6 months duration. This is effective and optimal to prevent the recurrence, but in many cases, systemic corticosteroid therapy alone is not the ideal treatment of lobular mastitis, and it has many side effects and complications, and sometimes a very, very serious complication may occur in a patient. And the recurrent rate reported as 15 to 50%. Indeed, failure to respond to systemic corticosteroids suggests the infective etiology, and culture for Corynebacterium should be considered. It is usually administered after surgery in complicated resistant cases and when surgical margins are dirty with the aim to reducing the recurrence rate. It could also be used before the surgery in a manner like breast cancer, in large unresectable lesions and or more diffuse lesions to be downstaged and become more localized and amenable to successful surgical excision. This is a meta-analysis, recent meta-analysis for 12 studies, including more than 500 patients, and the conclusion of this meta-analysis recommend the combination of steroids and surgery has a superior efficacy than the surgery alone or the corticosteroid alone. In our practice, we recommend systemic corticosteroids in patients with extra memory manifestations like inflammatory arthritis, arthralgia, and erythema nodosum of legs only for short periods to avoid the side effects and serious complications. Erythema nodosum, the presence of it in granulomatous mastitis indicates that the condition become more severe and the course also become longer, and here the corticosteroid is highly recommended. Methotrexate is another choice, immune suppressant drugs, dose 10 to 15 milligram weekly for 3 to 6 months. It is only indicated for resistant cases to maximal dose of corticosteroid or fail to respond to a second cycle of corticosteroids. Bromocriptine. The bromocriptine could be used in treatment of this disease based on that the prolactin causing overstimulation of the breast parenchymal tissue, and some cases of recurrent granulomatous mastitis has a high level of prolactin, but this is not constantly observed in all cases. The first one who described the use of bromocriptine is Agha Janzada from Iran in his largest series till date. He used bromocriptine in recurrent cases or resistant cases for steroid in addition to corticosteroid with good response in about 30% of his patients. So what about the antibiotics? Traditionally, there is a limited rule for ordinary antibiotics. It should be guided by the results of microbiologic culture where there is a secondary infection. But this concept has been changed in a recent article from USCA. They identify the bacteria in 50% of their patients and recommend the requesting of Corynebacterium detection in the specimen that referred to the laboratory, and also recommend an extended course of lipophilic antibiotic, which may be effective with low associated morbidity. So lastly, rifampicin, we have described for the first time rifampicin in 2017 and published our experience in the World Journal of Surgery. The hypothesis of using of rifampicin coming from that the data supporting the infective etiology like Corynebacterium. So we hypothesize that mixed infective microorganisms may be involved in pathogenesis, and most of these atypical microorganisms, which are difficult to isolate under ordinary culture. Also, we hypothesize that most of these may respond completely to rifampicin by mechanism similar to that of Mycobacterium tuberculosis. So our study, including 30 patients, proved that the efficacy of rifampicin therapy regimen of 300 milligram twice daily for a period of 6 to 9 months with complete clinical and ultrasonographic response without any recurrence episode during that period. So rifampicin could be used solo medical alternative to both surgery and corticosteroid. Here some patient with granulomatous mastitis treated only with rifampicin without any surgical interference for 9 months. Another case, 9 months of rifampicin therapy, and the patient do domestic dressing for management of sinuses till its complete resolution. Many cases treated with rifampicin only. The number of cases now, today, reaching about 130 patients without any surgery or corticosteroid. And this is the ultrasonic follow-up of one of our patients with complete resolution after 9 months. We have reported the progress of clinical findings and ultrasound during rifampicin treatment. So finally, could we put an algorithm, simple algorithm for management of granulomatous mastitis? Yes, we can classify the patient into 3 categories. Localized small lesion, the main line of treatment is observation, especially pregnancy. Intermediate lesion, and large diffuse or complicated lesions. In those types of patients, the last 2 categories, we can depend on patient preference, either initial excision or corticosteroid. And if there is failure of one of modality, we can switch to another modality. But rifampicin could be used as a medical therapy alternative to both surgery and corticosteroid in both categories, intermediate, large, diffuse, and complicated, and could be optimized by adding bromocriptine with frequent ultrasound-guided aspiration, which can be used sometimes, especially in large collections, more than 4 centimeters. In conclusion, granulomatous lobular mastitis is a chronic inflammatory breast disease, mimic carcinoma, TB variety of inflammatory conditions. Milk stasis plays a key role in pathogenesis. Milk-induced autoimmune mechanisms may be modulated by presence of Corynebacterium and other mixed organisms, especially atypical Mycobacterium. It is characterized histologically by non-caseating granulomas of lobulocentric pattern and often associated with microabscess formation. The self-limiting nature emphasizes the need to tailor treatments according to disease severity. We have many options for management, and in my practice, rifampicin is effective treatment with very low recurrent rate and could be alternative to both surgical resection and systemic corticosteroid, in addition to bromocriptine. And finally, I think granulomatous lobular mastitis is not a surgical disease and could be treated only medically. Thank you.
Thank you so much for your comprehensive talk.
It is pleasure and honors to present Dr. Ayman Abu Shmila for this topic, nipple discharge.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, my dear professors and my dear colleagues, I am honored to be with you today. First, I'd like to thank Professor Maher Hassan and the organizing committee for inviting me to be with you today. I'm going to talk about nipple discharge. Nipple discharge is a fluid that leaks from one or both nipples. Each human breast has 15 to 20 milk ducts. Nipple discharge can originate from one or more of these milk ducts. Nipple discharge is the 3rd most common breast complaint promoting medical care after breast pain and breast palpable mass. Accounts for 7 to 14% of all breast symptoms. And we know that over 80% of females will develop an episode of nipple discharge during their fertile life. Nipple discharge can be a complex diagnostic challenge as it can be completely benign and due to excessive nipple stimulation, or can be a manifestation of a wide variety of diseases. due to the global fear of breast cancer, an increasing number of women are asking their healthcare providers about nipple discharge. So we know all that most of the other cases are benign. 80% of the patients will experience nipple discharge. So what is the problem with nipple discharge? The problem that this is annoying to most of the patients. When you see this picture, we can see that Linus is eating her bobby, but actually from the other picture, she is transferring our protective hair. So when describing or putting the consideration of the patient that she is afraid of cancer, the clinician must be acknowledgeable and regarding the best practice for evaluating nipple discharge to convince the patient and to assure her and to reach the accurate diagnosis and the management. The classification of nipple discharge can be categorized as lactational, physiological, or pathological, according to clinical history and the characteristics of the discharge. Lactation nipple discharge is considered as a normal milk production expected during pregnancy and lactation and may persist for up to 2 years postpartum after cessation of breastfeeding. After spontaneous or intentional termination of pregnancy can occur, and when a milky nipple discharge occurs in females without recent history of pregnancy or lactation, it is called galactorrhea and commonly involves bilateral multiple ducts being the result of an inappropriate increase in prolactin release. Physiological nipple discharge is termed as any discharge caused due to a pathology outside of the breast, not related to a breast disease. So it is a benign entity, usually bilateral and usually white, green, or yellow in color. It involves multiple ducts and is associated with nipple squeezing. Some causes for physiological nipple discharge are following mechanical nipple stimulation, hyperprolactinemia, hypothyroidism, chronic kidney or liver disorders, and sometimes as a side effect of some drugs like antihypertensives and antipsychotics. However, pathological nipple discharge is that discharge causing due to benign or malignant breast disease. So pathological means it is related to the breast. So even if it's benign or malignant, this is called the pathological nipple discharge. This is defined as clear, serous, or bloody secretion, spontaneous, discharging usually from a single duct, and unilateral due to benign or malignant breast disease. And the most common cause of this discharge is usually benign breast disease, even if the discharge contains blood. For example, intraductal papillomas, which occurs in 35 to 56% of cases, or ductectasia. But an underlying malignancy can be represented in percentage of cases reported to be variable from 4 to 14% of cases. Most of the intraductal changes that lead to pathological nipple discharge are situated within 1 to 4 centimeters of the nipple. Like fibrocystic changes of the breast, ductectasia, intraductal papilloma, infection, breast abscess, neoplastic processes, and breast trauma. According to the character of the nipple discharge, we can expect what is the pathology. So it is if serous or serous this occurs in ductectasia or breast cancer, colored creamy, greenish, yellowish, or brownish, or black. This occurs with ductectasia. If bloody, the first consideration is ductal papilloma. Also, breast cancer, usually DCIS may occur. Fulminant streptococcal infection, and if it passes, we should consider abscess formation. How we can diagnose for nipple discharge? The first diagnostic workup of females with nipple discharge includes clinical history and physical examination, and I think this is the most important issue in the diagnosis. Also, conventional imaging, including mammography and elastography, are usually performed. These investigations are not always able to exclude an underlying malignancy, so we may need other investigation like cytological examination, galactography, dactyloscopy, and MRI. Sometimes, because the differentiation between a benign from a malignant etiology of a pathological nipple discharge based on clinical and diagnostic assessment is not easy, surgical excision may be considered the main way for getting both definitive diagnosis and eliminating the symptom. Clinical history plays an important role for evaluating the probability of malignancy. The patient age is very important, as women greater than 40 years of age are at higher risk of having pathological discharge. Postmenopausal women with nipple discharge are rarely benign. The presence of BRCA1 or 2 mutations and the presence of history of previous breast cancer are predicting factors for malignancy in the presence of pathological nipple discharge. Previous breast biopsy with diagnosis of atypia is also considered a predictor of malignancy. In a study including 318 patients with nipple discharge, either spontaneous discharge or observed during breast examination, Seltzer has reported a higher incidence of breast cancer equal to 9% in females over 50 years old, while the incidence was the only 1.3% in younger patients. So in our clinical history, we must know the onset of discharge, the association with menstrual cycle, persistence, and the character of the color of the discharge. The patient reproductive history is important, and the history of pregnancies and at first full term. Other relevant histories, including history of any breast problems, included in breast biopsies and surgical history, are required. In premenopausal women, obtaining the pregnancy birth history and history of breastfeeding and the use of oral contraceptives or hormonal replacement therapy is very important. Family history should contain information about cancers, especially breast and ovaries, and the menopausal status of close relatives. Medication history is important, as many medication can cause nipple discharge as a side effect, and one must not miss the presence of fever, because this may be a mastitis or a breast abscess, and symptoms of hypothyroidism, or liver disease, or symptoms of pituitary tumor, like visual changes, amenorrhea, a headache, to narrow down the differential diagnosis of nipple discharge. On breast examination, the patient should be examined for the presence of any breast masses. When we found a breast mass, we treat the patient like a breast mass, not a nipple discharge, and we should also search for asymmetry and skin changes and all signs of breast cancer. Palpation should include all the 4 quadrants of each breast and the bilateral axilla, supra, and infraclavicular areas to look for masses, swelling, tenderness, and lymphadenopathy. If no spontaneous discharge is visible, the examiner should attempt to extract the discharge by applying even pressure from the periphery towards the nipple. One should identify the quadrant that is involved by applying pressure to the breast, and this is a way the affected duct can be easily localized, and we should describe what is the expressed discharge. Is it unilateral, bilateral, single, or multiductal, and the color or nature, spontaneous or expressed. So nipple discharge should be alarming if spontaneous, bloody, or serous, unilateral, uniductal, sticky, and associated with a suspicious mass. However, postmenopausal nipple discharge of any character is significant and requires further evaluation. Also, nipple discharge in men is always abnormal and also must promote an evaluation. The primary goal of evaluation of the nipple discharge is to distinguish patients with benign discharge from those with underlying breast cancer. Our aim is to exclude the presence of malignancy. These patients, whose age, history, and physical examination suggest benign cause of their discharge, may be reassured and discharged without outpatient follow-up. We see some of those patients are treated with microdectomy and major duct excision in a very young age without even having suspicious. So those patients can be treated with follow-up. However, in patients with high risk for a pathological process as a cause of their discharge or with worrisome history and the physical examination, further investigation should be done. The first question we answer is it physiological or pathological discharge? So for patients with physiological discharge, we should ask for TSH level, and the prolactin levels are measured to rule out systemic causes of nipple discharge. And for patients lesser than 40 years of age, routine observation is required. For patients greater than 40 years of age, mammography and the mammosonography is indicated. For patients with pathological discharge, mammography and the ultrasound are performed. If abnormal image-guided biopsy is performed, fluid cytology, especially if bloody nipple discharge, may be requested, and if normal, then breast MRI will be requested. Which investigation? Ultrasound offers a better performance than mammography for detecting intraductal lesions, improves the evaluation of retroareolar region and ductal system that can be obscured in patients with dense breasts. Ductectasia, defined by the duct caliber greater than 30 millimeter, is one of the most common findings as well as on ultrasound, and it appears as dilated retroareolar ducts containing anechoic fluid or hypoechoic debris. Intraductal papilloma appearing as a hypoechoic nodule with central vascular pedicle on color Doppler ultrasound is helpful in differentiating intraductal viscous secretion versus intraductal nodule with vascular sign, and irregular duct margins, wall thickening, or hypoechoic intraductal mass with acoustic shadowing are ultrasound malignant features. Mammography represents the first conventional imaging technique to investigate nipple discharge at least after 40 years old. Mammography findings that are suspected to be associated to an occult malignancy can range from microcalcification, masses, focal density asymmetry, architecture distortion, or ductal ectasia, or otherwise no abnormality can be identified. Mammography has low sensitivity and limited accuracy in the detection of retroareolar lesions that are often small, intraductal, and without calcification, and also ultrasonography is better in these cases. Nipple discharge cytology is performed by squeezing the nipple with a gentle compression of the areola and spreading the secretion onto a glass slide. After smearing, the slides are immediately fixed by spray fixation or by immersion in 95% ethyl alcohol and then stained. It is a simple, fast examination, easy to perform and painless, but strongly limited by a low sensitivity for cancer with a false negative rate over 50%. Mammary ductoscopy, unfortunately we don't have this in Egypt, but it was first introduced in Japan in 1980s. This allows for direct visualization of the duct system. Its role is to localize intraductal lesions and to identify the ductal anatomy mapping to guide excision and allow tissue sampling and cytology. Therapeutic role in intraductal excision and laser ablation of intraductal papillomas. Fiber optic improves the optical resolution and allows for magnification and smaller carabin and working channels admit brush and basket and the biopsy forceps. This is a picture. First we do some sort of dilatation, then the ductoscope is introduced and markers using dye or clips are help besides identification of the lesion and ensure excision at open surgery and accurate pathological assessment. These are some pictures of the ductoscope. MRI, the contrast enhanced MRI allows detecting a mass enhancement or non-mass enhancement lesions. The main MRI finding in patients with pathological nipple discharge is non-mass enhancement. Segmental and linear non-mass enhancement is more often associated with malignancy. Intraductal papilloma appear as a well-circumscribed mass with homogeneous enhancement. Other times, ductal or segmental enhancement can be seen in both papillomas and papillomatosis. Dilated ducts appear as a signal hyperintensity on T2 weight imaging or as an area high signal intensity in pre-contrast T1 weighted sequences if endoruminal high protein or hemorrhagic content is present. Contrast enhancement MRI allows imaging for both breasts with a good visualization of the retroareolar region. It outlines enhancing pathology in good details, thereby providing physiological information in addition to the morphological detail provided by mammography and ultrasound. Also permits to detect multifocal or multicentric disease or to find an occult contralateral lesion. This MRI ability can play a crucial role when a pathological nipple discharge involves more than one duct or it is unclear which duct is involved. The treatment of breast discharge depends on the etiology. A physiological discharge doesn't require any treatment, just assurance of the patient. Systemic causes of nipple discharge require specific medication as control of hypothyroidism or hyperprolactinemia. Benign causes of breast discharge like duct ectasia require microductectomy or total duct excision, what's called major duct excision. The problem in that case is either to ask the patient for her need for further lactation. So the patient, if needing further lactation, we may be recommending microductectomy. Otherwise, major duct excision may be advised. In duct papillomas that produce unilateral bloody discharge require microductectomy. And in breast cancer, producing bloody nipple discharge requires surgery and or chemotherapy or radiation depending on the staging of the disease. In even cases of DCIS or invasive ductal carcinoma undergoing major duct excision with wide local excision, this can be expected as adequate surgery, provided that we can achieve safety margins from all over. And this actually needs a professional histopathologist. So a link with from the surgeon with the histopathologist is a must in these cases. So he can to confirm that the adequate safety margins are present. Prevalent discharge is treated with appropriate antibiotics, and abscess need image-guided aspiration drainage. For a long time, surgery has been considered the standard approach to pathological nipple discharge. Operation consists of either total subaerial major duct excision and microductectomy, and the benefit of microductectomy is the preservation of the remaining ductal system in continuity. I will conclude with this algorithm. If a case of nipple discharge, good history taking and physical examination should be done to conclude is it a physiological or a pathological nipple discharge. If it is a physiological, if it is due to systemic cause, we do medical treatment in cases hyperthyroidism and hyperprolactinemia. If it is physiological with in a patient under 40%, we can go for observation. Patients more than 40% years, we go for a mammosonography. And if the cause of a lesion is intraductal lesion or a breast mass associated with ductal biopsy, then we go for a biopsy, either image-guided biopsy. If benign, this is for follow-up. If it is a high risk of malignancy, we go for surgical excision. From the start, if mammography or ultrasound have negative findings, we need to restore to breast MRI, or by the end go for surgical excision, either microductectomy or major duct excision. Thank you.
Thanks, Dr. Ayman, for these concise and interesting topics as usual.
Okay, our next speaker is Dr. Walid Al-Nahas from Al Mansoura University. His talk is going to be about the breast implant associated with ALCL.
السلام عليكم. هو في الحقيقة طبعا I will talk about a topic of lymphoma, and is not common, and I think until now there is all the cases are worldwide reported, but I think we should know everything about this topic. We know that the types of lymphoma either arise from the B cell or the T cell. The breast implant associated large cell lymphoma anaplastic large cell lymphoma is a peripheral and uncommon peripheral T-cell lymphoma. It arises around the textured surface breast implant placed for either reconstructive or cosmetic indications. Always the course of this type of lymphoma is indolent, but however, reports of disseminated disease, there is a lot of cases with disseminated disease, but always the prognosis is very excellent in this type of lymphoma if diagnosed early. The pathogenesis is understood, but not understood, but usually it is related to the chronic inflammation related to the implant and the textured implant especially, like chronic immunity or autoimmunity, but there is a patients usually have genetic predisposition. This is okay or not okay, we don't know, but all related to the chronic inflammation related to the surface implant. There is chronic inflammation, T-cell dysplasias, in lymphocyte infiltration and the production of a specific cytokine causes indirect stimulation of the malignant lesions. Due to the predominance of textured cases and the concern of textures biocompatibility, the ANSM Institute in France instituted a black box warning of a clearly established link between breast implant and lymphoma. The epidemiology of breast implant anaplastic large cell lymphoma is uncommon but increasingly well described now because the surgeons be aware now of this type of lymphoma. Most cases present approximately about 1 decade after implant placement, also earlier or later cases can be. Median age of onset approximately 50 years of age. There is, I think now, more than 800 cases of pathologically confirmed anaplastic large cell lymphoma and 36 deaths from this type of lymphoma. From all the cases, about 620 were attributable to allergen biocell textured implant, and from the deaths we know 16 only is the type of implant, 15 of them due to allergen breast implant. And so I think the most common type of textured implant discovered was allergen, and this type of implant, I think, it is withdrawn now. It is not present, and so either it is related to the manufacturer, and but there is also few cases reported to another companies, but most of the cases reported to the allergen manufacturer. In Netherlands, they found that the people with implant has 18-fold higher rate of ALCL arising in the breast among women with breast implant compared to the women without implant. Also, the patients use the implant for augmentation or for reconstruction is equal. The number of cases published annually has increased with the formal recognition of breast implant and anaplastic large cell lymphoma because the surgeons, especially most of the cases of implant use was the plastic surgeon, and the presentation was the plastic surgeon, and so when we become aware of this type, so the number of cases become more discovered. In July 2019, the FDA called for Class 1 device recall of allergen biocell because most of the cases are due to using the allergen textured implant. Women with breast implant should perform regular self-breast examination and contact their health care provider if they notice any change. This is the patient because there is about 30 million have implant. But the screening or prophylactic implant removal is not recommended for women with breast implant who are asymptomatic, even with familial susceptibility to cancer. So the clinical features of this type, most of cases arise in the scar adjacent to the silicone or saline filled implant, 7 to 10 years after the implantation on average, but it can be earlier, 2 years, or after 32 years. Most of cases unilateral, but bilateral cases is reported. The most common presentation of the case, 60% presented with effusion. If late developed effusion is developed more than 50, because usually there is a small small fluid amount around the implant, but if it is larger than 50 or 100 cc around the implant, so you should suspect that. The seroma may be associated with breast swelling, asymmetry, or pain, and the seroma is more viscid and has more protein. 70% of cases presented by a mass related to the implant, 20% post-mass and effusion. Also, there is a rare cases presented with capsular contracture, and there is cases presented by lymphadenopathy in about 17% of cases. So the laboratory try to make a laboratory markers about blood tests for this type of lymphoma, but always it's normal. The pathologic features, if we take this fluid, we will find the morphology large cells, pleomorphic cells with abundant cytoplasm and horseshoe-shaped or embryoid nuclei. On immunohistochemistry, this is the most important. The anaplastic large cell lymphoma breast implant associated is positive for CD30 and negative for anaplastic lymphoma kinase, and this is the most important. So what we'll do if we found a case? The clinician should maintain a high index of suspicion, because if there is a fluid around the implant and we leave it, sometimes it's normal, but sometimes it is not normal. And so the clinician should maintain a high index of suspicion. Seroma more than 1 year after placement of the breast implant should be aspirated and screened for breast implant associated large cell lymphoma by doing CD30 and immunohistochemistry. And cell block from this fluid, we demonstrating anaplastic large cells, flow cytometry demonstrating a T cell clonal population. For the breast implant associated ALCL, CD30 should be positive and ALK should be negative. So the diagnosis needs this tumor adequate pathological specimen and related to the capsule, neoplasmus large anaplastic lymphoid cells, tumor demonstrate T cell with CD30 positive and ALK negative. So what's the staging? After we diagnose, what's the staging? If we use the Lugano modification of the Ann Arbor staging system, we will find that all the cases of the anaplastic large cell lymphoma is early, either 1E or 2E. And so this is, there is cases more aggressive, especially with lymph node involvement. So the NCCN use the TNM staging for this type of lymphoma and not the Ann Arbor, and stage it like the solid tumors. And so this is TNM, use the classifications, the TNM for the lymphoma like the solid tumors. The anaplastic large cell lymphoma breast implant associated should be differentiated from primary breast lymphoma, systemic ALCL, primary cutaneous lymphoma, nodal ALCL, primary or recurrent breast cancer, non-malignant complications of breast implant, including breast infection, because we should know that this T cell lymphoma, secondly, positive for CD30, negative for ALK. There is some types of lymphoma and should be related to the capsule, not the breast tissue. So the other types of this, some type of B cell lymphoma, some types arise away from the capsule, and this may be primary P cell lymphoma. So what we will do for the patients? So firstly, all patients with suspected breast implant ALCL, ultrasound imaging guided sampling, aspiration of the fluid. So the answer will be breast implant associated confirmed or rolled out or intermediate diagnosis. We don't know this is ALCL or not. If the breast implant associated lymphoma confirmed, firstly report, second oncological consultation, and PET-CT for the staging. For the localized cases and what we want to say, complete surgical, the treatment is surgery. And this is surprising for us, the main line of treatment for one type of lymphoma is surgery. The early stage is surgical, complete surgical excision, and remove of the implant, remove any disease mass with negative margin, total capsulectomy for patient with bilateral implant, remove the other implant for the risk of contralateral lymphoma. What about the lymph node? Sentinel lymph node is not permitted for this type of lymphoma. Also, the FNAC is not permitted. If any suspected lymph node excision biopsy only is recommended. It's not recommended to do sentinel and not recommended to do fine needle. The excision biopsy should be. So if we found lymphoma surgical treatment in the early cases, this is the capsule surrounds the implant. Removal with safety margin will be enough without any chemo or radiotherapy. But if unresectable, salvage may be irradiation, or if there is lymph node involvement, chemotherapy as for, and this is according to the usual protocol for ALCL lymphoma. So if we rule out second, the lymphoma, so we will deal as benign seroma. What about the intermediate diagnosis? Ask for second pathology at a tertiary cancer center. So the answer will be confirmation or rule out. What about if the diagnosis remains uncertain? Surgical exploration should be and the biopsy from the implant capsule. It will lead us to confirm breast implant associated ALCL or to rule out the breast implant associated ALCL. The follow-up for the patient, schedule patient for visit at least every 6 months. In each visit, we will perform history and physical examination and annual breast ultrasound at least 2 years. Following definitive treatment, implant replacement with a textured implant is not recommended because the patient, if we remove the implant, ask for another implant. The time we don't know who went to bought, but if we accept and we told the patient about the risk, we should replace by smooth implant. The prognosis usually good, but there is a bad prognostic factor if there is a mass or extracapsular extension or there is bilateral disease. The medical legal consideration, we should inform the patients in the consent about the risk of lymphoma, and I think we should even, with the use of smooth implant, which is available now in Egypt, we should inform about the risk. The risk is very low with this type of implant, but it is reported to have with also a smooth implant. In summary, the breast implant associated large cell lymphoma is a rare and treatable type. It is not a cancer of breast. It should continue to be discussed with any patient considering breast implant as part of the informed consent process. The lag time between implant insertion to diagnose breast implant associated ALCL has been from 2 to 32 years with a median of 7 to 8 years. The disease may affect aesthetic as well as reconstructed patients. This is not for reconstructed patients. The majority of patients should be CD30 positive and ALK negative. PET-CT and MRI scan are investigation performed following a positive diagnosis. Mammography has no role. Incomplete capsular resection has been associated with post-recurrence and a significant lower survival. The majority of patients can be cured of their disease by bilateral total capsulectomy and implant removal. Rare patients will present with a mass and have an increased risk of requiring radiotherapy and chemotherapy. Further research needed to determine the exact role of breast implant in the etiology, to determine whether some women have a predisposition to the development of this disease, and to determine if there are any patients or implant modifiable risk factors. So I want you to know that the average woman risk of developing breast cancer is 1 to 8. And the risk of death in car accident is 1 to 572. And the risk of death from complication from cosmetic procedures is 1 to 50,000. And the risk of development of breast implant associated ALCL is 1 to 3,870, and in some reports 30,000. And this is what I wanted to say from this. If it is very rare disease, And even if the breast implant, textured implant is available again in Egypt, I will use it other than allergen. And I think the patients, if I walk and the electricity fall over me and anyone die, I think the incidence is more than the incidence of this disease. And thank you very much.
Thank you, Dr. Walid. Next speaker, Dr. Sahar Mansour. The talk, Reconstructive Breast Surgery from the Radiologist's Perspective.
مساء الخير. Thank you so much for your introduction here. أنا عايزة أشكر دكتور ماهر لأنه خلاني وأنا radiologist part من surgeon session, which is يعني حاجة we appreciated a lot as a radiologist. أنا دكتور سحر منصور، أنا أستاذ في القصر العيني تخصص breast surgery أو breast cancer يعني، وأنا المدير الإداري للمبادرة الرئاسية بالقصر العيني للكشف المبكر على سرطان الثدي، وكونسلتنت في بهية Foundation for Breast Cancer and Treatment. I'll talk about the breast reconstruction imaging modalities, and first we can say that the breast reconstruction is always being requested for patients after mastectomy, breast cancer who are ineligible for the breast conserving therapy, and those with high genetic risk. When we do the reconstruction, we had to be familiar about the appearance of the reconstructed breast, and there is a spectrum of imaging findings that we have to find through the imaging processes. We have after skin sparing mastectomy, the imaging will demonstrate a skin flap and skin envelope, and there is also the nipple sparing mastectomy with a skin sparing mastectomy or subcutaneous mastectomy. Breast reconstruction option may include, as the previous surgeons have informed us, about the autologous tissue transfer for the flaps, and there is also the autologous fat grafting and prosthetic implants in grafts of the glandular tissue. For the reconstruction with the autologous flap, the use of the flap consisting of the autologous skin and subcutaneous fat, and sometimes for breast reconstruction patients who prefer the implant-free reconstruction. We have the TRAM, the transverse rectus abdominis mycutaneous flap. There is some variability in the vascular supply of the flap, and also we want to eliminate as much as possible the surgical complications. And so before doing the flap, please consider imaging as well, not after doing the flap only. For before the flap, we need to do CT angiography in order to go for the planning of the identifying the size, the location, and the course of the perforators in the lower abdomen. The perfect modality is the CT angiography. It's the modality of a choice, and we also may use the color Doppler ultrasound, but it has no radiation, yet it's have less sensitive and low positive predictive value. There is also the MR angiography, but it's not so much available in most of the centers. After the autologous reconstruction, we have a reconstructed breast, so it's available to do mammogram as the patient is in its normal entity. The breast is entirely fatty, which is very perfect for us as radiologists, because once there is recurrence of the cancer, it will be so much easily spotted. In this case here, we have the cancer. It's very easily could be detected because it's a dense lesion, small, tiny one in the entire fatty, loosened breast. And on the ultrasound, this could be easily detected on target, even if it was even 3 millimeter or 4 millimeter cancer. But negative mammogram on the autologous flap is not always conclusive. Why? Because sometimes the patient takes hormonal therapy, and so this increases, again, the density of the breast, and also there is a failure of evaluation of the axial lymph nodes, so it's better to confirm your examination, mammogram and ultrasound for the patient with the reconstructed flap. In this case, we have here the flap is clear, yet we have an axial lymph nodes, which is pathological. In most situations, benign post-reconstruction changes is easily distinguishable, but sometimes it's overlap with the malignancy. So first we go to the mammogram and ultrasound, as I said previously, and then if we have a debate or a dilemma about any dilemmatous condition overlapping between the recurrence, we go for the MR mammography as the second choice. It's not our first station. Breast ultrasound with a seroma like this, we have sometimes some septations and some hematomas, but on the MRI, we're definite about they are dealing with a cystic collection in relation to the flap, and it's the definite diagnosis of a seroma. Also, sometimes you have the calcification with the very expected fat necrosis after the reconstruction with the loosened halo, and yet it has a variable appearance on the ultrasound. Sometimes the cyst without or with echogenic content, sometimes the mixed mass or a solid mass with purely defined margins. And on the ultrasound, we can get these variable appearance that may overlap with recurrence, get us the delamatous condition, and so it's better, again, when we are not easily distinguishing it is a benign postoperative changes or it's a recurrent carcinoma, go to the MRI, and when we found there is a fat signal intensity within this collection or with these circular structures within the breast, we are evident about we are dealing with a postoperative benign fat necrosis and not definitely a recurrence. In patients who undergone radiation therapy, there is diffuse thickening and trabeculation in the reconstructed breast in the first 6 months to 3 years, which may also overlap with recurrence if we are doing the regular mammogram and ultrasound. So it's better to do MRI in such conditions in order to be definite that we are not dealing with recurrent, just the lymphatic affection from the operation. And also, one of the most favorite conditions about the MRI is not the pathological condition, it's also actually in the normal appearance, because it traces the muscle flap very clearly and there is no overlap between it or any other masses, unlike the mammogram, which may appear as an indefinite density within the mammogram and may overlap with having recurrence in the breast. And especially in patients with the residual breast parenchyma, we can see here that the parenchyma here, this is of the normal breast, and this is of the reconstructed breast. And so it's very important to distinguish both of them because the element of recurrence will be in the normal breast, and it affects the long-term surveillance imaging of the patients with the residual breast parenchyma. And if I'm having a lesion deeply seated inside in relation to the muscle, I may easily distinguish it from a recurrence because the fat necrosis has the loosened fat signal within. This is the black signal intensity areas within. So I'm dealing with enhancing fat necrosis, yet here it's totally solid with viable tumoral tissue enhancing, so it's a recurrence and easily distinguished with them. While in the mammogram, we can see that we are dealing with both densities. They are the same on the mammogram, yet on the MRI, distinguish is so much easier. In the pedunculated tram flap, there will be the course of the rectus abdominis muscle, also the inframammary fold to the mastectomy pocket with the superior epigastric artery, and the folded rectus abdominis muscle is easily distinguished in the deep central portion of the breast. And what about recurrence? Actually, it's very distinguished on the mammogram. When we get a malignant mass, could easily detect it, will look like the primary tumor, and the ultrasound, it's more sensitive than mammography for detecting the occult recurrence, especially if it was less than 0.5 centimeter. On the MRI, as I said earlier, it will be easily distinguished from the flap, even if it is with deeply seated. What about contrast-enhanced mammogram, which is more friendly and more accessible to the patient? You could easily go through it in the same setting with the mammogram. Well, actually, at this site, you're having the overlap between the fat necrosis and the recurrence. Both of them look almost on the mammogram with the fishy indistinct pattern, and the Indian contrast-enhanced mammogram will get the marginal enhancement. Yet on the MRI, we have the fat loosened center that could distinguish us between the recurrence and the fat necrosis. We have the embryo reconstruction with the autologous fat grafting by injecting a fat within the confine of the mastectomy bed. In the fat grafting, the fat tissue is removed from other parts of the body, like the thighs, belly, and the buttocks, and then the tissue is processed into liquid and injected again into the breast area to create the breast confine. Lipofilling is used to fix the minor differences in the shape and position of the reconstructed breast. We use it with the nipple sparing, so please, when you consider nipple sparing, do MRI for better before the examination or contrast-enhanced study, because in order to assess this type of operation, we need to be so much evident about the size of the tumor being smaller than 3 centimeters, and if there is intraductal extension, as we can see here in this case, although the tumor is so much tiny, but we have here in post-contrast imaging, there is intraductal extension that will not be evident on the mammogram. It's not the suitable type of operation for it. In this case, we had here the removal of the breast with a mastectomy and do the post-operative lipofilling with the MRI showing the same appearance of the mammogram. And finally, we get to the reconstruction with the prosthetic implants. where the implant-based reconstruction can be performed as a one-step approach. The implant directly is inserted into the retropectoral space. Or as two steps, we do a tissue expander and start to inflate this expander until to get the size that's comparable to the other breast and get a permanent implant. The expander, we have here the opening that we give it from it, to expand the implant is anterior to the implant. And this is very important and the crucial item to distinguish between the expander and the implant. The expander, the opening to fill it and to make it comparable to the other side of the breast, is anterior to the expander. While in the implant, we could find here that the valve is in posterior to the implant. Okay, so when you go to see any imaging, do not overlap both of them. The expander, the filling is anterior and the implant is posterior. Of course, for the radiologist, we can easily distinguish from the signal intensity, from the pattern of the outline of the tissue, but for the surgeon, the expander, we have its valve anterior, and for the implant, it's posterior. We have, yes? Okay, without opening anterior, okay. Okay, أنا كنت بشوفه في القصر العيني الحقيقة. Okay. Breast reconstruction involves the use of prosthetic implant. The implant could be saline solution or silicone or both. It's very important to follow up the implant because sometimes there is cancer recurrence and sometimes there is silent implant rupture, and there is no significant difference in breast cancer survival rates between those with or without implants. Here we can see that we have an additional sequence in the MRI, which is called the silicon suppression sequence. We could suppress the implant in order to distinguish between the implant and the tumor, as because we have seen in the previous sequences that the implant has a high signal intensity similar to the tumor. But with the silicon suppression sequence, we can suppress the silicon and get only the cancer, and this is after removal of the tumor and the application of another implant. Also, we can see if there is post-operative right muscle flap and do implant on one side and the flap on the other side in order to get the symmetrical size. Fibrosis is one of the sequelae of the radiation therapy in the breast and one of the challenges in evaluating reconstructive breast surgery. It's very crucial to differentiate between the fibrosis and capsule contraction of the implant or its rupture. And the intracapsular rupture, can we see that the implant is not homogeneous anymore. Inside it is what is called lingual sign. It's similar to the macarona lingual sign, or there is heterogeneity in the pattern of the implant. We have to distinguish between the post-radiation therapy, the silent implant rupture, and if there is tumor recurrence. And in this case, we have a tumor here deeply seated and have eaten the implant with a consequent or secondary intracapsular rupture. There is a specific technique, Alcan technique, in order to image the implants with the mammogram, with the displacement of the breast posteriorly and getting the implant anterior, but actually this is not accessible in case of the reconstructive breast surgery because there is the element of fibrosis due to the radiotherapy, and it's not accessible in most of the cases to perform such techniques, so it's better to do for the reconstructive breast surgery the MRI. It gives us the impression about the silent intracapsular rupture where there is this heterogeneity within the implant. It's not homogeneous anymore, and so even if the size remained at the same pattern and configuration, yet we can distinguish its intracapsular rupture or it is the normal by getting this inhomogeneity in the pattern of the implant. And also the retroimplant mass, if there is any, is easily detected and could be targeted. Also, there is assessment not only of the reconstructed breast to the other breast, because sometimes the breast by itself is normal and the implant is homogeneous and very fine. Everything is okay with the left breast as is here, but we have carcinoma here in the contralateral side with assessment in the same setting. So when we get the mastectomy, either to do the routine case and the patient stay with her no breast, or do the reconstruction. And if we do the reconstructive breast surgery, despite of the different variants, we go first to the digital mammogram and the ultrasound, as I said earlier, for the flap better, and for the implant we go to the MRI. If we had no recent clinical abnormality, or we have no questionable findings, the digital mammogram and ultrasound is the perfect modality. But if there is questionable findings overlapping between some fibrosis, between fat necrosis, and if there is a recurrence, or there is a recent clinical abnormality, we should go for a contrast-based study. So what's about the contrast-based study? It's a contrast-enhanced mammogram or MRI No, please, in case of reconstructive breast surgery, skip the contrast enhanced mammography because we still have the overlap in the contrast pattern. Go to the MRI because the MRI give us first the impression about the normal reconstructive breast surgery, not just about the complications. Also, it differentiates very clearly between the fat necrosis and the recurrence. For the deeply seated lesion, this is the perfect modality, and also for the silent rupture implant. It's very important, the multidisciplinary meeting, in order to get the appropriate imaging, not always to do such a scheme. It's not a template, because every patient has its own surveillance rate and its condition about the modality used for her. It's very, very important to give a communication between the surgeon, oncologist, pathologist, and radiologist to ensure the follow-up in the evidence-based and to establish what is called a tailored optimal post-treatment surveillance for the cancer recurrence. Thank you.
Thank you.
Questions after the session, I guess.
Yes,
Questions
thank you,
after the
Dr.
session.
Asah. Now the floor is open for discussion. Before last talk, this is, I think, last talk symposium will be postponed or we'll start now? Doctor, to start discussion now according to. Dr. Ashraf?
For the patients also. I'm just asking about the preference of the types that you use in the fluid type, as you mentioned in your lecture, because the easy, I think, the lymphatic vascular, which is as easy as the shunt that it is done in for those who are going to do renal lavage or something like this. This is one question. The second question, what about the redo? For how many times you can say that there is a failure of what I did and I have to redo my reconstruction again?
Thanks for the two important questions. So number one, let's start with number two first. Number two, when do you decide if you have a failure or something? So those patients, we perform every 3 months we do follow-up for the patients regarding multiple parameters, the quality of life of the patient and clinical examination and circumference measurements. And based on that, after 6 months to 1 year, we decide whether what we have done is working or not. And if you look carefully to the algorithm, there are always backups. Like, for example, if the patient has fluid predominant, if he does an LVA and it doesn't work after a year or so and he's still fluid predominant, we can do a lymph node or a lymph vessel transfer. Even the patients which are solid predominant to start with, they do liposuction, and then after 1 year, we noticed that many of those that didn't have functional lymphatics to work with to start with has developed functional lymphatics, and then we can do an LVA or a vascularized lymph node transfer a year after the liposuction. Regarding the first question about the LVA, right?
Yes.
So is the question about how do we...
The preference, this is the easier, because you mentioned, you mentioned 3 types of, 3 ways of reconstruction.
Right.
And
so
I think this is the easiest. Do you prefer it every time, or you think...
It's not the easiest, to be honest.
Yes, okay, it's okay. I think
it's super microsurgical.
For your presentation,
yeah, I agree with you that it's more or less like the shunt that's done in the renal patients, but the technicality is a bit harder. So we use magnification of 25x with a microscope, of course, and we use those super microsurgery instruments with less than 1 millimeter tip, and we use 11.0 or 10 or 12.0 sutures to hook the lymphatic to the vein. apart from the difficulties in finding the lymphatics in the veins as well. But yeah, I mean, whenever we do that, the more we do that, the more easy, as you said, to perform it. And actually, yes, it's after I mean, excelling the technique, it's going to be an easy one for a super microsurgeon, of course. But sometimes you don't have lymphatics to work with. I mean, there is a pathological sequence for the lymphatics that undergo after lymphedema. First, normal lymphatics, and second, they become ectatic, like they become bigger and wider. And third, they become sclerotic and fibrotic. So sclerotic and fibrotic, which are the third and the fourth grade of the pathological sequence of lymphedema, are not effective and are not easy to work with. And usually, you will gain nothing out of them. So the ICG lymphography, the machine that I have showed, will tell you if that's a functional lymphatic or not. A functional lymphatic will stain white, and you can see it on the screen, and then you can mark it, and then you can open over it and get a vein and do the LVA. But in case you didn't find a functional lymphatic in the ICG, that's one indication of switching the indication and use another way of physiological operation like the vascularized lymph node and vessel transfer. So to answer your question, if you didn't find a functional lymphatic to work with, then you can switch to lymph node transfer or lymph vessel transfer.
Thank you, that's nice.
I have 3 questions.
Yeah,
First,
one question. You have only one question. No, 3 questions. We have all these questions.
okay. So for
هو داخل كده على طول الشيخ ده مش عارفين نكلمه.
خش على الثلاث على
برضه
طول.
وتر. هو الواحد وتر برضه.
For Dr. Sahar, I have one question.
Okay.
Is mammography is contraindicated?
لا احنا لسه still with دكتور اشرف. احنا we're taking in order. انا فاكر هتكلم عن دكتور اشرف. Okay, Dr. Ashraf, I'd like to ask you another question, please, because definitely you tackled a very important issue. I think who's going to solve it is going to have a Nobel Prize, because all the time we keep bluffing our patients, telling them they are going to be okay and nothing is going to happen.
Right.
And you described the fluid type lymphedema, and I just want to ask, what are your inclusion criteria? Don't you try in such a situation, the physiotherapy, the sleeves are going to be okay? Instead of going to such a complicated surgery? This is number one. And the second one, the liposuction you applied in the solid types, these you showed us only localized types. The lymphedema patients are diffusely involving the whole limb, and sometimes they are firm. I think it's not going to be feasible that you are going to apply such a liposuction in all these patients.
A good question. Number 2, we'll start with number 2 as well. So yes, liposuction in a solid predominant disease has an immediate and excellent results. That's very gratifying and very rewarding, and that change the quality of life of the patient immediately. And as you said حضرتك إنه إن هي we do liposuction in the forearm and sometimes in the hand itself. So we can do liposuction in the hand, in the forearm, and in the arm. And even in the primary lymphedema cases, that's not our interest now, but we do also in the foot, in the leg, and in the thigh. So yeah, you can do the liposuction with excision in the arm, like the cases I showed, and you can do it all over the limb, in the forearm and in the hand as well, if you have an extensive lymphedema. So the question number 1 about the physiotherapy. Of course, the physiotherapy is an integral part. Maybe I didn't have time to show what exactly our protocol regarding the physiotherapy. So physiotherapy, whenever we see a patient and diagnose the patient, most of the patients come from the physiotherapy first. And then we send the patient back to the physiotherapy to start an extensive course of physiotherapy that lasts for at least 3 weeks. And then sometimes when we do the ICG lymphography, we don't find any lymphatics because the lymphatic fluid is occupying a good amount of the subcutaneous tissue that would let the lymphatics not showing in the ICG. So we send the patient back to the physiotherapy, then you do extensive course, and then we repeat the ICG, and sometimes we can find functional lymphatic to work on. Some patients will benefit from just physiotherapy depending on the stage of the disease. So, and now we have a clinical staging, and the most important is the ICG staging. I didn't have time to show the different dermal backflow pattern that we see in the ICG lymphography, but there are certain patterns like what we call the dermal backflow pattern. If they show in the ICG, that's a straight indication for surgery. If they don't show, we can work on physiotherapy, and not forever. I mean, we work for physiotherapy for 3 months, and then we reassess the patient, and 3 months, and reassess the patient, and so on. So the clinical staging and the ICG staging and the response to the physiotherapy would tell if this patient will continue on physiotherapy or is indicated for surgery.
I think you have an online question.
Yeah, sure. I think this question is not for me.
It's for me.
Yeah.
It's for Dr. Walid, it's not for him. لخبطتيني انت. لا اصبر طب ما تسألينا. Okay. Thank you very much, Dr. Ashraf, for your presentation. It has been marvelous work, and I congratulate you and your team for this elegant work.
Thank you very much.
Okay. Our next speaker is Dr. Omar Farouk. Is any questions regarding the issue of granulomatous mastitis? Because this is a very hot topic, and I think you describe it perfectly. You give us a very excellent review about it. And I want to congratulate you on one thing on the conclusion at the end, which you told that is not a surgical disease.
Thank you.
Okay, تفضل يا بيه. فين المايك يا جماعة للدكتور؟
عاوز اشكر حضرتك على البرزنتيشن، كانت تو ذا بوينت وميتيكولس، وحضرتك قلت كل الكوزز بتاع الجرانيتس ماستايتس. احنا عندنا في عين شمس اكسبيرينس مع الكورتيكوسترويد. انا عارف حضرتك في الاخر قلت ريكومنديشن ريماكتان بس، ده اللي انا فاهمه صح كده؟ اللي حضرتك ماشي على ريماكتان از ا ميثود اوف تريتمنت في جرانيتس ماستايتس.
هو السبب ان لغايه الان نو كونسنسس في العالم كله. بالزبط. هي كلها اكسبيرينس، وبعدين معظم الاستاديز اللي هي published, most of published are case series.
تمام.
The largest one is from Iran by Agha Janzada on 2017, and most of cases during in this large series treated with corticosteroid with some rate of recurrence. But the era or the time of this publication below a paradigm shift. Paradigm shift has done on 2017. After that, the infective theory coming strongly by many articles from many countries all over the world, and so the door opened for alternative drugs like rifampicin and bromocriptine. In my experience, I has treated more than 130 patients without by rifampicin as the solo.
That's what my question. As a solo uni treatment as a Remactan. Whatever the stage of granulocytitis, if it's contain abscess, if sinuses, if skin affection, all of them are treated by Remactan only.
احنا بنعلم العيانه بنقول لها ان ده ريكومنديشن ان هي تعمل حاجه اسمها دوميستيك. هي دي اللي بتزعج الجراحين، ان هو كل شويه العيانه جايه علشان الساينسس والابسس وكلام من، فاحنا بنعلمها انها تعمل دوميستيك دريسنج للفتره اللي بتقعد فيها الساينس. غالبا بتقعد لها من 10 ايام لاسبوعين up to 3 weeks، وبيحصل لها complete resolution and could be repeated. لكن لو في بالالتراسونيك، واحنا يعني كجراحين يعني ما اسمح لنا يعني ان احنا يبقى معانا الترا ساوند كبيت سايد انفستيجيشن اثناء الفولو اب، لو لقينا كوليكشن اكبر من 4 سم ده بنعمل له اسبيريشن، وده مش موجود في معظم الحالات. تقريبا في حوالي نسبه من حوالي من 10 up to 20% of cases. ده بيوبتمايز الريفامبيسين. وريسنتلي بعد ما نشرت البيبر دي في 2017 على كل الحالات لازم اديها بروموكريبتين، لان احيانا الريفامبيسين ما بقاش موجود، ولو ان مستشفيات الصدر بدات تصرفه للعيانين بس بيدوه كجزء من الانتي توبركولاس ريجن، على اعتبار ان في يعني ميس دايجنوزد في كتير من الحالات لحالات من التي بي ماستايتس.
احنا ماشيين ببروموكريبتين او انتي برولاكتين وات ايفر دوستنكس زائد كورتيكوستيرويدز. بس انا عاملين رول بقى، ده الحاجه برضه ماشيين فيها ستادي فور ميجور داكت اكسيجن بعد ريزوليوشن.
في ستادي اتعملت وانا شفتها، بس انا لما تابعت الموضوع الدكتكتيزيا في العيانين بتوع الجناس ماساس it is not primary disease, it is secondary due to accumulation of fluids back flow بيحصل في الضغط. ومع البروجريس بتاع التريتمنت هي القضيه ان هي عايزه محتاجه صبر من العيان والسيرجن. يعني لما بنقول 6 شهور ل9 شهور بنكتشف ان كل حالات الدكتكتيزيا اللي كانت اسوشيتد بالالتراسونيك في البدايه كلها بتختفي عند 6 ل9 شهور.
احنا خدناها بالعكس، احنا قلنا الفكره بتاعتنا اللي هو احد الثيوريز اوف جرانيولوماتوس ماستايتس از في مشكله في الميلك سكريشن او الميلك ديسكومينيشن من الدكس. فقلنا لو شلنا الدكس احنا هنمبروف الثيوري دي، وفعلا ادت معانا على فكره مارفلس نتائج لغايه دلوقتي.
يعني لسه نوت ادكتال ديسيز، مولكيولار ديسيز.
حسن كتير، انا في الاستاد زي عاملينها محسنه كتير قوي افتر ريزوليوشن عشان نقلل الريكارنس.
هي اكسبيرينس، احنا ممكن نعمل راندومايز.
الموضوع بتاع الجرانوماتوس ماستايتس ده يا جماعه اتس ايشو. اعتقد احنا كل واحد لو سالناه البراكتس بتاعه كل واحد مختلف.
هي يعني محتاجه راندومايز ترايل.
احنا يعني طبعا كل واحد اكسبيرينس بتاعه مختلف عن الثاني. اي بيرسونالي لو بحد كورتيكوستيرويد اي ثينك وي اسك ذا بيشنت تو بيكام بيشنت وتروح وتيجي معانا تبقى ريكارنت. لو جالها ابسس كولكشن تبقى اسبريتد، لو ساينس بنكحتها بتروح وتيجي معانا العيانه كذا مره بعد شهور بتقفل. يعني I don't know ممكن ريماكتان طبعا we tried ريماكتان with good results sometimes it does not give good results. بس ساعات كمان availability of ريماكتان is not present، والعيانين في الصدريه لازم يجيب له كالتشر عليها تي بي عشان يصرف الدواء. ف it's a problem يعني. فانا I think يعني البراكتس بتاع كل واحد مننا اعتقد هيبقى مختلف، فمش هنوصل لكونكلوجن يعني. اتفضل يا بيه.
ريزوليوشن سنه سنتين بالمتابعه ورجع تاني، هل نستمر على نفس الريجمنت برضه 3 to 6 months ولا الريكارنت كيسز
يعني لو هنتكلم على الريجن اوف ريفامبيسين فور 6 to 9 months نسبه الريكارنت اللي حصلت لا تتعدى حوالي 3%، وكان سببها ان العيانه دخلت بعد الفول تريتمنت على طول في انذر بريجننسي، يعني دخلت في ريسك تاني في موضوع اللاكتيشنال بروبلمز. فبعد ما خلصت البريجننسي الريزيدوال الديسيز اللي كان موجود عدنا تاني الريجن، بس عملنا له اوبتمايزيشن بالبروموكريبتين.
لا انا ما بتكلمش على ريفامبيسين بس، يعني انا ساعات بدي ميثوتريكزيت وكورتيكوستيرويد وبيحصل ريزوليوشن. لو سنه سنتين وجالي كارنس تاني، هل ادي نفس الديوريشن ولا اقل، ولا راي حضرتك ايه؟ هل في بيبرز عن الريكارنت جرانيولوماتوس ماستايتس؟
الريكارنس اللي انا شايفه في الليتريتشر ريليتد في كتير من الاحيان للبرولاكتين ليفلز، مش في البلاد وانما في موضوع البرولاكتين ريسبتور اب ريجوليشن او اوفر ستيميوليشن. فيمكن ده البروموكريبتين adding to any regimen is good choice for those patients like Aghajan Zada as he did in his large series.
I think
كده انا متفق مع دكتورنا ان بعد التوتال ريزوليوشن وانا مشيت على وات ايفر ريفامبيسين، مشيت ميديكال، ان انا اعمل ميجور داكت اكسجن بتقلل فعلا الريت اوف ريكارنس كتير يا دكتور عمر.
لا اسمح لي
نعمل
علاقه الدكتس بيها برضه difficult to imagine يا عماد.
It is not a ductal disease.
معظم الحالات بتبقى في فترة الفطام أو following pregnancy. فالحقيقة أنا متفق مع الدكتور، هو ما فيش كونسنسس كويس.
I don't think يعني.
فالميجور داكت اكسجن فعلا بيقلل الريكارنس بعد الكومبليت ريزوليوشن
ده بيرسونال اكسبيرينس يا عماد، ما اعرفش يعني.
كله بيرسونال.
اصل ده امبورايزيشن، ده ماشي مع اللوبيولز جوه البريست تيشو.
كله ليفل 4 ايفيدنس بيزد ميديسن.
ضغط اكتيزيا يا دكتور
علاء. اوبزرفيشنال يا جماعه.
السكندري ضغط اكتيزيا نوت برايمري، يعني it is not a ductal disease.
احنا مش هنقعد بس ايه نلخبط الناس. اعتقد بقى كده كفايه على دكتور عمر. ناخد الثيرد برزنتيشن دكتور ايمن ابو شميله regarding nipple discharge. حد له سؤال يا جماعه؟ اتفضل يا باشا.
Is there a significant role for cytology for nipple discharge? I think in modern oncology nipple discharge cytology is
ما احنا قلنا ان هو
very limited role.
النيبل سيتولوجي او السيتولوجي بيتعمل، لكن هو الفولس نيجاتيف بتاعه up to 50%. هو كويس ان انت تشخص بيه انترادكتور بابيلوما، لكن ان انت
when you ask for cytology for from nipple discharge, every case with nipple discharge I will ask for
simply you go for the less invasive to the more invasive. So although it is for example MRI is the best radiological investigation, but I will not start with MRI. I'll go first for ultrasound, and if the patient is above 40, I go for mammography and ask for cytology. So, but by the end, you should know that the dilemma of nipple discharge is mainly to have a diagnosis from the first, based on your the history taking and good physical examination. Then after this, you go for investigation. So I will go for cytology, but you should put in mind that you have a false 50% up to 40% false negative results.
هي اسمح لي لو اقول لك حاجه بالنسبه للسيتولوجي، لو انا اقول لك رايي يعني. هو طبعا زي ما قال الدكتور ايمن كلامه يعني عمل برزنتيشن جميله جدا، بس الفكره the cytology for nipple discharge diagnostic yield بتاعه مش كبير، لكن you select which patient to give do cytology اللي هي the patient having a significant nipple discharge اللي هو دايما بنقول عليه ايه spontaneous bloody uniductal، ولو especially if it is associated with the breast mass. كل الحاجات دي بتخليك تبقى more or less you are more or less this is a pathological. يعني الحاله اللي بتبقى مثلا زي ما بيقول عليها دكتور ايمن قدمها لنا البلادي نيبل اقل من 40 سنه، ساعات بيبقى السيتولوجي بيدي لك بابيليفرس سيلز وتديك suggestion of papilloma and that's it يعني. لكن حاله مثلا جايه لك باكسبريسبل مالتي داكتال سكانتي ديسشارج what's the indication to do cytology؟ ده اللي اقصده يعني. انت عايز تقول حاجه ثانيه؟ كنت عايز تقول حاجه
على فكره دكتور احمد برضو يعني انا بتفق مع حضرتك في نقطه مهمه، ان هو المشكله النيبل ديسشارج ان هو حتى ايفن لما نيجي للليتريتشر مفيش داتا كتيره ومفيش بيبرز مكتوبه كتير. انا الثيسيس بتاعتي كانت في 2002 عن النيبل ديسشارج، من ساعتها لغايه دلوقتي مفيش بابليكيشن قد كده. النقطه ان هو انا في وجهه نظري ان هو في ميس مانجمنت او ميس واي اوف ديلينج مع النيبل ديسشارج. المشكله ان البيشنت بتجيلك هي غالبا خايفه من بريست كانسر، ومعظم الحالات دي بناين اصلا، فهي نفس القصه. يعني انا لما ما حطيت الصوره دي انا حطيتها مقصوده. انت لازم تكسكلود بريست كانسر، لكن هو في النهايه معظم الحالات دي بناين. فانت you should يعني exhaust yourself first in history taking, in physical examination, and then go for the simple and then go for the more invasive.
دكتوره كان عايزه تعمل كومنت.
انا عايزه بس اقول ان النيبل ديسشارج من حلاوتها
ورا في سؤال كمان.
فمش محتاجه يعني انا مش محتاجه سسبكت ولا احتاج سيتولوجي ولا غيره. هي لو جايب كانسر هتجيلي ببليدنج بيرنيبل، هتجيلي بسنجل اورفيس.
وعلى فكره برضو حالات بتيجي بليدنج بيرنيبل وهي في الاخر ما هيش بريست كانسر.
بالظبط، عشان كده انا المفروض
احنا خلينا بس متفقين ان انا هرجع تاني. انا في رايي it is history taking physical examination
يعني هي لو عملنا الترا ساوند هنقدر نشوف الدكتس كلها، وبالتالي لو حاجه فيها ليجن هقدر بقى يبقى عندي بابيلوما خلاص، حتى لو هي مش بليدنج بنيبل، حتى لو هي وايتش ديشارج، ما انا عندي اكتوال ليجن. الام ار اي ما بيجيبش تايني ليجنز، انا الالترا ساوند اللي مور سبيسيفيك عشان
المشكله يا
اروح للام
دكتوره
ار
في
لازم يبقى
الالترا
ماس
ساوند،
كبيره.
الالترا ساوند ساعات بيبقى انتوا ما بتعرفوش تفرقوا، ساعات بتفتح في الدوبلر بابيلوما وحاجه من
لا
دكتيزيا
الاكسبرت راديولوجيست، لا احنا عندنا
ده
فايندنجز
اللي
اوف
اقصده
فيتشرز.
يعني.
اي نو
ساعات
ان في
بتبقى
ساعات اوفرلاب،
الريبورت
لكن
كده.
الاكسبرت راديولوجيست بيقدر يفرق بين الاوكلت السكريشنز الانتسبيسيتد وبين الماسز، ولينا دوبلر، ولينا بنقدر نعمل حركه تاكتال بريمتس بنضغط عليها كده بتبتدي تتحرك، العينه تقوم او تقعد، يبتدي مكان اللوكيشن بتاعها يتحرك، فطبعا definitely this is not a papilloma. بنبقى very definite about it، بنقيس لكم المقاس من البابيلوما to the nipple، وبنقيس extension of the duct dilated، وطبعا لما تبقى duct لوحدها بتبقى very suspicious، لكن انا لو عندي disease ما هلاقي كل الدكتس كبيره وهلاقي secretions فيهم كلهم بيبقى لهم ايكو باترن مختلف عن الماسز، فالالتراساوند this is the modality of choice.
بيتكلم هو كولكتيف، بيتكلم عليه ان الموضوع كولكتيف ما بيتاخدش من
انا ما بتكلمش على دكتكتيزيا بس.
بالظبط.
بس انا برضو كلمه اخيره يعني برضو في النهايه انا اهم حاجه ان انت ترول اوت بريزنس اوف كانسر. عشان كده البيشنت انت محتاج ان انت لو هي يونج ايج ومفيش كاركترز ان هي سسبيشس ليها، بس شد ان انت تنسيست على البيشنت ان هي تو فولو اب. يعني انت ايه برضو ما تخليش العيانه ايه تلوز منك، انت في النهايه انت محتاج ان انت ان البيشنت دي هي اندر فولو اب، لكن في نفس الوقت مش عايز ان انا يبقى كل حاجه ادخل عيانه مايكرودكتومي وميجور داكت اكسيجن فور ناثينج يعني.
انا عملت ليميتيشن جدا في حالات السيرجري في البناين، يعني انا في الكالر ديسشارج يلوش ولا براونش في يونج ايج انا ريرلي ما بيرفورم سيرجري. انا شايف لا انديكيشن اصلا.
وانا انا على فكره انا بحيي حضرتك على كده، بس على فكره ودكتور احمد يعني استاذنا ويقدر يرد علينا في النقطه دي. حضرتك قد ايه يا دكتور احمد من البراكتس من الدكاتره ما بيعملش كده؟ الجراح العيانه بتروح له يلا نيبل ديشارج مايكرو ميجور دكتور. ايوه اكشولي ما احنا عشان كده بنتكلم. هو اكشولي يعني احنا لما دكتور ماهر اتكلم ان احنا نتكلم في نيبل ديشارج، هو الموضوع يعني ما هوش حاجه، بس هو فعليا هو المال براكتس هو اللي بيحصل. يعني دكتور احمد ودكتور احمد يقولوا لنا قد ايه من العيانين حضرتك بيجي لك وهي عامله ميجور داكت اكسيجن وهي عامله مايكرو ديكوكتومي، وهي كل الحكايه واحده عندها شويه داكتكتيزيا ولا عندها فالفكره ان في ميس مانجمنت للحالات.
وبعمل بقى ميجور داكت كتير جدا في البليدنج بيرنبل اولد ايج ومعيش ديفينتلي.
ايوه ده انا متفق معاك، وعشان كده انا حطيتها في كوتيشن يعني اي بوست مولوبوزل نيبل ديشارج
ومفيش عندي فايندنج،
وحتى انا لا يو شود بي كونسيدرد انت كونسيدريشن الميل نيبل ديشارج يو شود بي كونسيدرد، لكن في النهايه برضو العيانين اللي هم
عشان الوقت. طيب السفيل حد عايز يسال
دكتور ايمن؟
الدكتور اللي ورا بس.
تمام
اتفضل
دكتور ايمن، شكرا جدا على المحاضره. انا سؤالي ساعات حالات كتيره جدا بتيجي بدكتكتيزيا بريست بين ونيبل ديسشارج، ساعات السونار يقول دايلاتيشن بتاع الميجور داكت حوالي 3 مللي، اكتر من 3 مللي كده. ساعات ناس تانية بتيجي بابسس، فهل في يعني علشان نافويد الانفلاماتوري بروسيس وانها تقلب بابسس، هل في مثلا حضرتك من وجهه نظرك او من خبره حضرتك شفت مثلا دكتكتيزيا should be done عشان ما نوصلش للقصه دي؟ لان الموضوع ده كتير يعني.
طيب بص، هو فيها هي الموضوع كومبلكس شويه، وساعات كتيره جدا بيبقى فيه some sort of inflammation وموجود في الحالات دي. عاده الحالات دي لو انا بنتكلم بقى في براكتس اللي هو سيلف براكتس، ساعات بختار ان هم البيشنت دول ياخدوا ميديكال تريتمنت جاست مع اشورنس. هو معظم الحالات دي بس اهم حاجه بقول لها ان هي ما تقعدش يعني سكويز او ان هي كل شويه تكسبريس النيبل ديشارج ده. بدي شورت لونج يعني لفتره قليله انتي بايوتيك، يعني حاجه من الكلونول موكسيفلوكساسين او حاجه مع انتي انفلاماتوري. بدي فرصه بس للبيشنت اتليست حتى نفسها ان هي تستوب الجزء، لان هو معظم العيانين هتلاقيهم ايه هي اللي بتكسبريس النيبل ديشارج، والطبيعي ان هي لو جبت ال 100 عيانه وقلت لهم اكسبريس هيجيبوا في الديشارج.
يعني معظم العيانين من البين، يعني كومبليننج من البين اكتر من
عشان كده بقول لك احنا بندي شويه انتي بايوتيك حاجه يعني مثلا كينولون مع انتي انفلاماتوري جاست ذيس از ا ميديكال تريتمنت وفولو اب.
ماشي. في اسئله ثانيه؟ كان في سؤال للدكتور وليد اونلاين. كانوا
هو حقيقة أنا أعتقد إن ده it should be asked to the pathologist, not to the surgical oncologist, because I think our role just to suspect. يعني the surgeon, I think we should suspect, and after suspect we will send for the radiologist to aspirate this fluid or to take biopsy from if there is a mass related to the capsule. And so I think it should be because usually the fluid is more viscid, more cellular, have more protein. It is different than the usual fluid around the implant, because every implant should be usually surrounded with small amount of fluid. But I think we will ask the pathologist about that.
اوكي دكتور انت عمر كان في سؤال، في حد تاني؟ دكتور وليد.
دكتور عمر بس
ما دكتور عمر كان عنده سؤال لدكتوره سحر. دكتور وليد يعني.
لا سؤال برضه للدكتور وليد.
طيب.
First I want to thank you for this highly illustrative talk. You have covered all questions. It is very rare condition, but I want to know, should we take a consent from any patient asking for implant that there is possibility for...
Yes, this is the recommendation, the FDA recommendation, because...
Can we do it in practice?
Yes, you should inform the patient in a small amount, even the smooth... Yes, the small amount, usually it is associated with textured implant. And now the textured implant, it's not permitted in Egypt and France only. And how many cases reported in Egypt? How many cases? 0. Okay, we don't know 0 because of
no
registration, or we don't know because most of the seroma post implant is shown by the plastic surgeon, not by the oncologic surgeon. You know, and this is equal. But you should inform, because there is a smooth implant is associated with also the same type of lymphoma, but with low percentage. You should inform the patient. It's mostly with the textured implant, but maybe with a smooth implant, but with a very low percentage. لا بتوافق.
السؤال الأخير بس يا عمرو عشان بس
مع الدكتورة سحر.
اتفضل.
لما بنعمل ايميجينج للحالات اللي عامله امبلانت، هل الماموجرام كونترا انديكيتد ولا هو نوت بريفيرد جاست لانه؟
لا اتس نوت كونترا انديكيتد، ولو كانت هي عامله امبلانت فور اوجمنتيشن بيتعمل لها الماموجرام عادي جدا، ما فيش مشكله. لكن في ريكونستراكشن بيبقى في فايبروز نتيجه الراديوثيرابي، فسمتايمز ان انا ابولي ذا بريست ات ويل بي ديفيكولت، غير ان هي عندها الاليمنت هاي ان انا يجي لي ريكارنس، والريكارنس ده ممكن يجي ديب تو ذا امبلانت ويجي في المصل، فبحتاج الام ار اي فور ذا demonstration for the breast itself anterior to the implant وللdeep portion اللي ورا الامبلانت، which is that's why the MRI is more applicable or more suitable for the reconstructed breast with implant. لكن for augmentation no, we can do the mammogram and ultrasound, even more for the reconstruction اللي بتتعمل في بهية، لأن هم الحقيقة ما بيبقاش عندنا قوي يعني the breast is not that stiff، في lipofilling، فالimplant takes its space عادي جدا، وafter the radiotherapy it will be very loose and the breast will take the normal configuration. بس في on general basis، لو أنا بتكلم in general basis reconstructive breast بيبقى subject أكتر للfibrosis.
It is better to do MRI for the reconstructive.
If you're suspecting something. But the usual no, we'll do the digital mammogram and the ultrasound.
Thank you.
Okay, thank you. Now last speaker, adapt. دكتورة شيماء النجار. adapt garment.
مساء الخير على حضراتكم. يشرفني جدا وجودي النهارده في المؤتمر، طبعا بدعوة الدكتور ماهر، شكرا لحضرتك ودعوة مؤسسة بهية. الحقيقه I'm not a doctor، ماليش قوي علاقه بالمجال الطبي. احنا شركه ادابت بتعتبر اول شركه في الشرق الاوسط بتعمل ملابس للمرضى بوست اوبريتيف بعد العمليات الجراحيه والكسور. اللي خلانا نعمل ده ان احنا لمسنا المشاكل اللي بتواجه المرضى بعد اي عمليه او بعد اي كسر، especially في carrying the drains. كلنا عارفين وشفنا قبل كده قد ايه المريض بعد اي عمليه لو شفناه حامل ماسك الدرينز او الدرنقات وماشي بيها ومش عارف يحطها فين، او مش عارف يروح بيها المتابعه بتاعه الدكتور، او يمكن يحطها في شنطه او احنا بنوفر ملابس للمرضى بعد العمليات الجراحيه بيكون فيها اماكن مخصصه لحمل الوعاءات او لحمل سواء بقى كانت يورين باجز او درينز او درنقات او ايا كان. تعاوننا مع مؤسسه بهية في ان احنا نعرف ايه بالظبط اللي بتعاني منه المحاربه بعد العمليه، ما يخصش يمكن المجال الطبي. فلقينا ان حمل الدرينز دي من اكبر المشاكل اللي بتواجه المحاربات، فبدانا ان احنا نعمل ليهم ملابس يحطوا فيها الدرينز. الجاكيت كاري اب تو 4 درينز، بتقدر ان هي تتحرك بيه جوه البيت او تروح بيه متابعه الدكتور، او يعني يمكن من الحالات اللي انا سمعت عنها وبعتت لي مسج ان هي كان عندها انترفيو مش عارفه تتوجه ازاي، تحضر ازاي، تروح ازاي الشغل بتاعها، فاحنا بنعمل ملابس مخصصه ليهم يحطوا فيها الدرينز. طبعا بتكون مفتوحه من بتكون مفتوحه علشان to access the wound under arm، بتكون easy getting on and off. وطبعا بنوفر كمان الدرينز بيلت، البيلت ده around the waist to carry up to 5 drains. بنوفر 2 types of bra for after mastectomy. One of them to put the silicone pads or the cup. We offer the cups دي هي breathable very light، وطبعا ارخص بكتير من السيليكون. السيليكون انا شفته ان هو تقيل شويه، فاحنا بنعمل لهم حاجه natural material cotton وايزي تو يعني سهل ان هم يحطوهم جوه البوكيتس، وطبعا وزنها خفيف جدا، اخف بكتير من السيليكون. وطبعا بتكون غلق امامي علشان ما يضطروش ان هم يحركوا دراعهم لورا. ريكونستراكشن برا برضو بتتقفل من قدام، بيكون فيها unwired panels to support the breast. ده small video for the طبعا عشان تلبسها وتقلعها بسهوله بتكون مقفوله وبتتفتح وتقفل من قدام، وبتكون من الكتاف طبعا فيها panels to support the breast. ودي pillow to protect the area of the wound. وطبعا عشان تسند عليها دراعها بعد العمليه، وبيكون فيها inside pockets to لو بتحط فيها كمادات او that kind of. وطبعا الكيمو سيشنز ده شيرت بيعمل وورمنج في during the chemo sessions، وبيكون في اكسس للتيوبز، بيكون مفتوح بسوست to access the tubes. طبعا بعد العمليه ساعات بيكون في الورم اللي هو الاورام الليمفاويه، بتكون الدراع متورم شويه، فبيكون صعب عليها ان هي ترفع دراعها بعد وهو وارم. فبنوفر جاكيتس للمحاربات بيكون مفتوح بسوسته علشان تقدر تاخد من خلاله الكيمو سيشنز، وطبعا بيعمل وورمنج during the session. وده مخصوص للتورم الليمفاوي. ده لبس عادي خالص، بيكون في انسايد ويتس في الناحيه اللي فيها التورم علشان المحاربات يعني تقدر توسع الكم اللي هي عايزاه او تديها واسعه اكتر عشان ما تبقاش ماسكه على دراعها او مضايقاها وتقلل من وتصعب الحركه بتاعتها. طبعا الشركه بتعرض منتجات لجميع التخصصات الجراحيه، جراحات القلب، جراحات الثدي، كل انواع الجراحات، بالاستعانه طبعا باطباء متخصصين علشان احنا طبعا بعاد تماما عن المجال الطبي، بس عندنا خبره في مجال الملابس كبيره استخدمناها في ان احنا نوفر للمرضى كل اللي هم ممكن يحتاجوه بعد اي عمليه جراحيه او كسور.
طيب الكوست بقى عن الحاجات دي، كوست از ات افوردبل؟
يس انا لو يس
يعني لو قلنا حاجه كده على بعضها سيت وان سيت شامل كل ده، يعني اسعار كوست
احنا موجودين بره يا دكتور نتكلم في الاسعار. لا الاسعار لا هقول لحضرتك انا بوفر ده للي محتاجه في اي مكان. انا موجوده في اسكندريه، انا من اسكندريه، بس احنا موجودين في مؤسسه بهيه طبعا. انا لا يعني احنا بنوزع في كل مصر بس احنا من اسكندريه. لا احنا موجودين في بنوصل في كل مصر وبره مصر كمان. المنصورة طبعا. هاجي لحضرتك يا دكتور ان شاء الله. شكرا جدا لحضراتكم. ميرسي.
شكرا. ثانك يو.